Hello and welcome to this lecture, which is a comprehensive review of major topics in psychiatry. Please understand that this is not an in-depth lecture on each of these topics, and there is also not a lot of management for each of these individual conditions. But I shall be mainly talking about the diagnostic criteria for these conditions as per the DSM-5, which is the Diagnostic and Statistical Manual version 5, devised by the American Psychiatric Association. The topics presented here may not appear in the same order as in DSM-5, but the diagnostic criteria are as per the DSM-5. So you can use this lecture as a quick revision of all these important topics just before you go for an exam. Before we get into the groups of conditions and individual disorders, let us begin with the basics of psychiatry and psychology, such as assessments, classification, and theories of learning and behavior. Theories of behavior, biological theory. Behavior is the result of biochemical or neurotransmitter changes in the brain, such as serotonin, right? Dysregulation of serotonin is related to depressed mood, whereas cognitive is thinking. Behavior results from the way a person thinks or interprets and chooses to react to an event, okay? So the classic examples of cognitive theories of behavior is cognitive distortions. Please don't get confused. In the context of behavior, cognitive means thinking. Whereas in the context of neurocognitive disorders, cognitive means higher mental functions, such as memory, language, and all those things. Okay? They are used, the term is used interchangeably. So don't get confused. Look at the context in which it is used. Cognitive distortions. Examples: overgeneralization, generalizing one event to cover all the events. I had a bad experience with one man, therefore all men are bad, for example. Excessive responsibility, it's all my fault that my daughter failed the exam. Arbitrary inference, I got out of the wrong side of the bed, therefore the whole day was spoiled, unrelated to, whatever. I'm giving an example of a superstition, but the underlying basis could be arbitrary inference. Catastrophizing, making mountains out of molehills. Failed one preparatory test, for example, and you think that you are not good enough to take the final exam. You're going to miss it. What's the point? Those sort of things. So all these things can give rise to anxiety and depression. Behavioral theories of behavior. Behavior results from a person's interaction with the environment. Under this, you have classical conditioning and operant conditioning. Classical conditioning is learning in which the stimulus acquires the capacity to evoke a response that was originally evoked by another physiologically relevant stimulus. Example, food, the unconditioned stimulus, naturally causes salivation. UCR, that is natural. You don't need to think about it at all. Whereas if you associate the unconditioned stimulus, that is food, with a tone, neutral stimulus, which has no association with food, that gets paired with food. So that now the tone, because of its association with the unconditioned stimulus or the food, becomes a conditioned stimulus. And each time you just ring a bell, a tone, even without the food, the conditioned stimulus triggers the same salivatory response as food. CS triggers the salivatory response, which will be CR, conditioned response. But it is important to remember that the neutral in the questions, for example, neutral is the same as conditioned stimulus, such as ringing the bell. That's always ringing the bell. An unconditioned response is the same as conditioned response, always. Dog salivating looking at the food, that is unconditioned response, it will still salivate. It's the same salivation even with ringing of the bell, conditioned response. Then you have operant conditioning, which takes it a step further than classical conditioning. Behavior results from the consequence of an action. Okay, so in classical conditioning, it is unconscious. The whole process is unconscious. Whereas in operant conditioning, there is some learning involved. Okay, consequence of an action, which strengthens or reinforces RF, the behavior, or weakens, punishes P, the behavior. Okay, so there is actual active learning going on in operant conditioning. So behavior is reinforced or increased when it is followed by something pleasurable. Okay, so that is known as positive reinforcement. You are giving something to increase the behavior. The act of giving is positive and behavior increasing is reinforcing. Or the removal of something, you can give or remove. So the removal of something also may increase the behavior, and the act of removal is aversive or negative. A behavior is punished or reduced when it is followed by something aversive. You can give something unpleasurable to reduce the behavior, and the act of giving something unpleasurable is positive. Or the removal of something pleasurable. You can take away some privileges, and the act of taking away is negative, and the behavior reduces. So very quickly, if you give good words, for example, praise, saying, hey, you did very well last time, it was great, amazing. So you're giving something, right? You're giving something pleasurable. That increases the behavior, whatever it was that the person did. Negative reinforcement. If you continue doing a good job, you don't have to clean your room, for example. Taking away the responsibility of cleaning the room is negative. The person will continue with a good behavior. Positive punishment, hitting if somebody does something bad. Child is swearing, mother hits. So the hitting is positive. And what happens to the swearing behavior? It will reduce. Positively punished. Removal of something pleasurable. Child is swearing and mother wants the swearing to reduce. So the mother will say, no more TV. So the act of seeing TV is being taken away. So that is negative. And what happens to the swearing? It will reduce. So that is negative punishment. Then you have social learning, which is behavior that results from observing and choosing to imitate a model's behavior, attitudes, or emotions. Not the ramp walk model. What we mean is the ideal behavior by somebody else. It could be a teacher, it could be a parent, it could be a peer. Their attitudes, emotions, and all those things. Choosing to act aggressively after observing somebody to act aggressively. So it can go both ways. Somebody can be an ideal parent, and therefore the child can look up to the parent and learn good behavior. On the other hand, the child can get into bad company and drug-taking behavior, for example. The child can learn smoking, drinking, taking cannabis, injecting drugs, and all those things. So this is all social learning. What is the term called where the child looks at somebody and behaves in a similar way? What is that learning called? Vicarious. Yeah, vicarious means from others. Psychoanalytic means you're going much deeper into the levels of unconsciousness. So behavior results from intra-psychic forces. That means within the mind and influenced by past relationships and the mind, the unconscious part of the mind and all those things. Childhood memories, dreams, all those things. Conflict between the intra-psychic forces, which are three: id, ego, and superego. Id is instinctual drive, means I want it right now. Ego is the sum total of the interplay between all these three forces, or the face that you show to the world. And superego is more like conscience, which says, no, take a step back. You can do better than this. Don't attack that person, those sort of things. So these may trigger a change in behavior as a defense mechanism. Example, acting opposite to one's true feelings. And as we know, there is a whole list of defense mechanisms. I mean, just repression, which is immature, putting away unwanted memories, as opposed to something like suppression, which is more mature, putting away unwanted memories or events to deal with them later on. That is the difference between repression and suppression. Acting opposite to one's true feelings, the example there. What is that an example of? I think that might be reaction formation, right? There is a whole list, as I told you, so please go through all those things. The operant conditioning specific examples or types: Factors influencing the effectiveness, that is active learning. Contingency between behavior and consequence is clear. There is a definite relationship between whatever behavior is elicited and the result of such behavior. Specified, immediate, and consistent. It happens every time. It is immediate, and it is specific to that kind of behavior. So use of both punishment and reinforcement to modify behavior, and the nature of chosen reinforcement or punishment. All these things are very, very important as far as effectiveness of this mode of therapy is concerned. Learned helplessness is nothing but inactively or passively accepting the fate, basically. So resulting from overuse or misperception of punishment. So it's like the rat which has which is being shocked, but there is a lever to, even if you present a lever to escape, over a period of time, the rat gives up because it is into a learned helplessness mode. Doesn't want to escape the pain, even when there is a chance. So that could be the underlying mechanism for the causation of depression. People with depression, they give up hope, basically. It's like saying, what is the point of me doing anything? Everything is doomed. Everything is worthless, hopeless, helpless. It's like that, okay? One of the theories of causation of depression. Shaping is successive approximation, developing the behavior by reinforcing behaviors that are incrementally closer to the desired behavior. For example, selective mutism. Child is not speaking at school, but speaking at home. So the psychologist will try and get the child to utter some monosyllabic sound like ma, da, whatever, and then encourage the child. Very good, you have done very well. So next, let's just progress to ma to mom. So that then the child progresses. And then you progress further saying, mom, the next word. What is the next word you want to say? So like that, successive approximations. Operant extinction, the process of weakening a behavior by stopping the reinforcement that was used to develop the behavior. So basically, if you just stop reinforcing whatever you are doing, positive or negative, taking away things or giving things, if you just stop that, the behavior also stops. Same as in classical extinction also. That is, if the association of the neutral with the unconditioned stimulus is stopped, it leads to extinction, okay, of the behavior. Operant schedules the rules governing the release of reinforcement or punishment. So it could be continuous. That means reinforcement or punishment occurs every time the behavior occurs. Okay, so each time you clean your desk, you will get 1 coin in your piggy bank. Understood? Every time. It's not at an interval or at the end of a month or something, every time. So that is the example of continuous operant schedules. Intermittent, obviously, it means it is not continuous. So under this, you have 2 types, ratio and interval. Ratio is response driven, number of responses, number, that is the key word. Whereas interval is time related, calendar driven, that is the key word. So if it is number, you know straight away it is ratio. Or if it is time factor, such as seconds, minutes, hours, days, weeks, months, years, then it is likely to be interval schedule. Does it make sense? So ratio, reinforcement or punishment is released after a certain number of responses, response driven. Interval, reinforcement or punishment is released after a certain amount of time, calendar driven. Ratio and interval schedules can be described as fixed or variable based on the predictability that the RF or P is released. Fixed means at a definite intervals or definite numbers. Variable means you just don't know when it's going to happen. It's very unpredictable. Yeah, I think we have examples for those in the next one. Ratio schedules. Examples, continuous every response. Each time a dog performs a trait, it is given a trait. Continuous. It is not after number of responses, it is not time related. Fixed ratio after a predictable number of responses. So a worker gets paid after every 5 units are made. sales executives. If you sell 5 units, you will get a bonus. That's an example of fixed ratio. Yeah, variable ratio after unpredictable number of responses. Worker gets paid after a random number of units are made. It's not fifth. It is just random as the boss desires. So that is variable ratio. Behavioral use disorders, such as gambling. Because you don't know whether you will be successful the first time or the seventh time or the ninth time, 10th time, 100th time, you can't say. So variable ratio schedule, example for, or could be an underlying mechanism for gambling addiction. Okay, behavioral use disorder, basically. Fixed interval, which is, interval means time driven. After a predictable period of time, a worker gets paid on the last day of each month. Salary is a classic example of fixed interval. You work for a month, at the end of the month, you get your salary. That's fixed interval. Variable interval, after an unpredictable period of time, worker gets paid on random days each month. So this is the biopsychosocial model of health. So to make a comprehensive assessment of all the psychiatric conditions, we consider that under various headings: biological, psychological, and social. Biological means all the physical or somatic aspects of health, such as any disabilities or genetic vulnerabilities. Psychological would include inner mental processes such as coping skills, social skills, self-esteem, and all those things. Socially, you will have to look at peer relationships, family circumstances, and school performance. Of course, there is a lot of overlap between these individual headings. For example, drug effects could be common to both biological and social. So there are social implications to drug use. Even though the immediate effects of drug use is seen on the body, it can have social implications such as job loss or relationship difficulties. So likewise, IQ, intelligence quotient, is decided by the brain functioning, but it is also a psychological test. It is arrived by doing IQ tests by a trained psychologist. And so also temperament and personality, which may be biological constructs, but they can have psychological effects. And family relationships, common to both psychosocial and psychological. Trauma, such as abuse or any dysfunctional family related issues, all those things can have both social and psychological implications. So in the middle of all these things, by managing all these parameters, mental health can be maintained. In fact, you can add a fourth circle to this and say spiritual aspects, because spiritual aspects mean going beyond the psyche or the mind. If you do that, all the mental issues will take care of themselves. So that could be further advancement in this model. But for now, try and remember biopsychosocial model of health. This will feature in both the assessment of psychiatric conditions as well as their management. You still need the biopsychosocial model for both. So we shall look into that later on. Etiology of mental illness, remember the causes. It's easier to remember by dividing them into the 4 P's: predisposing factors, precipitating, perpetuating, and protective, and consider those under various headings such as biological, psychological, and social. Predisposing means nothing but risk factors. So biological, it could be genetic, medical illness, psychological abuse, social dysfunctional families. Precipitating means triggers. Drug abuse is a trigger. Head injury can be a trigger for personality change if frontal lobe is affected. Stopping the treatment, mania, discontinued lithium. So that was a precipitating event, right? Stress, trauma, relationship breakdown, all those things. Perpetuating means continuing factors, the ones which make the illness to continue, even though the person might be taking treatment. So ongoing drug abuse, even though you are giving antipsychotic to a patient with schizophrenia, the person continues to abuse cannabis. Therefore, his illness is not under control. Untreated medical illness, you are giving antidepressants, but thyroid function is not under control. Okay, so depression is not going to be treated. Abuse, stress, again, relationship issues, high expressed emotions, which is very particularly problematic with schizophrenia, victimizing the patient, blaming the patient, scolding the patient. It is associated with relapse of schizophrenia, and therefore the illness can continue. Protective factors is the opposite. Is there anything which can prevent a relapse from happening, or make the condition go away, cure the condition? So compliance with treatment, especially in bipolar, if a person continues to take lithium or any other mood stabilizer or antipsychotic, mood is stable. Good premorbid adjustment, that is before falling illness. Resilience, they can overcome adversities. Family support, having a stable job or finances is good prognosis. Stable relationships, being divorced, single, risk factors for depression and suicide. Summary of assessments. So you have the assessment tools such as interview, and the interview could be open-ended or closed-ended. Open-ended means semi-structured. There is not much structure to it. Whereas closed-ended means it is very, very structured. It goes in a definite pattern about a person's functioning. So semi-structured interviews is nothing but the standard psychiatric history taking. What I mean is history of presenting complaints, past history, medical history, psychiatric history, personal history, premorbid personality. All that is part of psychiatric history taking, which is semi-structured. Whereas structured, the examples, DIS means diagnostic, interview, schedule, and SCID, structured clinical interview for DSM-5, right? So it actually helps in the making of DSM-5 diagnosis. Mental state examination. What do you do after a semi-structured history taking? The next step is mental state examination. So basically you look at appearance and behavior, speech, emotion, perception, thought, content and process, insight and judgment, and cognitive functioning. And as I keep telling you, I always add risk assessment because that is in direct relation to risk to self and others. So that's why it's very important to do that. So mental state examination is the overall terminology. The mnemonic to remember is aseptic. All these few steps under MSc. MMSc means mini mental state examination. So as the name suggests, it's mini. It's only one part of mental state examination. And that is, it only measures the cognitive component of MSc, whereas cognitive functioning is only one part of overall mental state examination. So MMSc is very, very focused on the cognitive component, and it is specifically like a screening instrument for dementia, neurocognitive disorders, basically. Okay, don't get confused. MMSc, just because there are more letters to it, it doesn't mean that it is more comprehensive. Mental state examination is more comprehensive. MMSc is just a part of it. 30-item test, screening instrument for dementias. Okay. So now intelligence tests, anything that yields an intelligence quotient, which basically tells you how smart person is or the capacity to solve the problems. Mental age, that is determined by doing tests, divided by chronological age, that gives the IQ. And the tests that are used to come at IQ figure is Stanford Binet test. More popular is WAIS, which is Wechsler Adult Intelligence Scale, and WISC is for children. WPPSI is for preschool and primary school children. Okay. Psychological tests, assessment of the way a person feels things and reacts. You have two types, objective and projective. So objective means psychological tests involving unambiguous questions, means very definite, such as true or false questions. Nothing vague about it. Okay, it's very, very definite. MMPI is Minnesota multiphasic inventory, right? Whereas MCI is Millen clinical multi-axial inventory. BDI, Beck depression inventory, so it's specific for depression. So projective tests are those tests which involve interpretation of ambiguous stimuli. So you do give vague stimuli here and let the patient interpret and let you know what he or she feels about it. Examples: Rorschach, devised by the person of the same name; ink blots, 10 ink blots, and you just compress a paper with ink blot on it, and you will get a symmetrical pattern on both sides. And you ask the person to interpret what it means. What is TAT, CAT? Thematic apperception test. Look at the pictures and they have to describe it. And CAT is children's apperception test. You show them cartoon pictures. Sentence completion is basically what it says. Incomplete sentence where the patient has to fill in with his or her own words. Word association, what's the first word you can think of when I say this word? Father, for example. So the patient will have to say the next word which comes to his mind and elaborate. Neuropsychological testing, comprehensive evaluation of a person's cognitive function to assess brain integrity. You understand what it means? So basically it is several times more than MMSE. MMSE is just a screening instrument. If you want a more definitive diagnosis, then you go for the full neuropsychological battery of tests, because there are so many tests, and the many tests depending on which type of lobe you are testing. For example, parietal lobe, it is Bender Gestalt test. What happens in that? Ask them to sort out geometric, say, shapes and figures, right? Why? Because what is the function of parietal lobe? It is praxis and gnosis. Therefore, you are going to test for apraxia and agnosia. 3D relationships of objects, basically. That's what it means. And frontal lobe test, remember frontal lobe is also concerned with executive functioning. What is WCST? Wisconsin card sorting test. So you ask them to sort out cards, playing cards, and they have to inhibit or go for the movement. So inhibition, restricting, and then doing the movement, it's all part of executive functioning. Stroop test is writing the color in a different, name of the color in a different color. And they'll have to identify the color and not read the word. You understand? So that also is in executive functioning. Other tests, inventories to quantify or qualify an aspect of a person's functioning. Example, frequency and antecedents of a behavior. There are different types. Cognitive, such as thinking. What were you thinking when you did the act? Which may be useful in eating disorders, diaries. Behavioral, what were you doing instead of thinking before the act? Which is like you can have a sleep inventory. Why did you sleep poorly? What was your behavior before that? Bodily inventories. You can also measure physiological parameters such as BP, pulse, which are related to behavior. Summary of classification. So once you assess the condition, you have to categorize them. So categorical classification means assigning definite categories to each condition. So it is mood disorders. Depression is mood disorder. Schizophrenia is psychotic disorder. Alcohol use disorder is substance use disorder. So under various categories, dementia is cognitive disorder. So categorical is vertical, under various headings. Whereas dimensional is horizontal, across the board, spectrum, okay, or a continuum. Because what begins like an anxiety disorder may progress to become a mood disorder and finally end up being a psychotic disorder, right? Typical example is body dysmorphic disorder, which is like an anxiety disorder, which is, preoccupation with some facial defect. And the more the person keeps on being fixated with it, one fine day, the overvalued idea or the anxious idea becomes of delusional intensity, and then it becomes a psychotic condition, okay? So that is what we mean by dimensional nature of conditions. For example, again, there, mild, moderate, severe depression progressing to psychotic features, depression progressing to psychotic features. And then you can't distinguish between psychosis and mood disorders. ZUD code conditions. So any other conditions that may be a focus of clinical attention, that is one of the DSM-5 terminologies. Examples would include uncomplicated bereavement, which is expected to pass, by the way. Acculturation difficulty, which is like people going to new cultures and or new foreign countries and trying to get adjusted. And if there are issues with acculturation, it will lead to adjustment disorders, right? Typically, immigration problem, changing a place, getting retired, adjusting to divorced life, all those kind of things. Yeah. Whereas specifically, we're talking about acculturation difficulty, trying to get adjusted to a new culture. Victim of crime, which can be common, but the impact can be too much to handle, and that can lead to post-traumatic stress disorder. Provisional means patient information is currently unavailable, not enough information, okay? Or symptoms are present, but the duration is not met. So you've got to look at both the aspects of the NEDSM-5 criteria, duration as well as the number of symptoms, okay? If any two of these are incomplete, then you put provisional after the diagnosis, such as schizophrenia, provisional, with the hope that with the passage of time, you will get more features that will become positive. Or if you get some collateral information from somebody, a family member who is not present right now, who will be able to confirm that, yes, that feature is also present, and therefore you can change the provisional to a full diagnosis. Whereas unspecified means criteria within a broad diagnostic category is present, but not splitting into anything specific, like, for example, eating disorders. Some features of binging is there, but weight loss is not there. It is not fitting into binge eating disorder also. So then you would have to call it unspecified eating disorder, personality disorder, whatever. And there you put unspecified before the illness, before the name of the illness. So prior history means condition in remission and unlikely to relapse. That means let's take an example of major depressive disorder, prior history. The person has had one episode of depression sometime in the past. And he is very resilient. He's been taking treatment, good family support, and the condition is unlikely to relapse unless he has some significant life events. Therefore, you can just call it prior history. Unlikely to relapse, that is very important. Whereas in remission means condition is in remission, but it is likely to relapse because by nature, it is a relapsing condition. Classic example is alcohol use disorder. It could also be mania because by nature, it is a very recurrent condition. It could be a panic disorder because we know by nature, panic disorder is very, very recurrent. Okay. So in those conditions, you just say alcohol use disorder in remission. Management of mental illness, again, go by the biopsychosocial table. Management includes investigations and treatment. Always remember this. No matter which field you are studying or practicing in, management includes investigations, treatment, medicine, surgery, OBG, psychiatry, wherever. Okay. So under investigations relevant to psychiatry, biological would be blood test, ECG, MRI, chest X-ray, if necessary. Psychological rating scales, every condition has a rating scale, as I keep telling you. IQ testing is an example. Neurocognitive assessment is an example. Personality tests, Rorschach and all those things, they are all psychological investigations. Social occupational therapy assessment, which is like home environment assessment. Housing needs assessment, what kind of house is suitable for which kind of condition. Vocational skills assessment, what kind of job skills the person has, all those things. Treatment, biological treatments would include psychotropic drugs, medicines, yeah, antidepressants, antipsychotics, and all those things. ECT, electroconvulsive therapy, passage of electric current under sedation, not just sedation, anesthesia, RT unmuzzled relaxation, RTMS, transcranial magnetic stimulation, DBS, deep brain stimulation, and all those things. Examples of psychological treatment, cognitive behavior therapy, psychodynamic psychotherapy, relaxation therapy, family therapy, marital therapy, interpersonal therapy, dialectic behavior therapy, which is specific for borderline personality disorder. That's the only condition in which it is done. Social psychoeducation of a family, because they wouldn't know much about the mental illness. Child care, housing, vocational training and vocational placement. Financial assessment, because there could be financial burden, especially is a risk factor for suicide, as I keep telling you. So address all those issues. So the examples of biological therapies, psychotropic agents, nothing but medications. So what do? Neurotransmitter modulation. Examples: antipsychotics, antidepressants, mood stabilizers, anxiolytics and hypnotics. Indications for antipsychotics: psychosis, such as schizophrenia, but also behavioral disorders, including like violent behavior without any underlying mental illness, or dementia-related restlessness and delirium-related violence, agitation. You can still use, but be very careful about using in elderly. Antidepressants, depression and anxiety. Mechanism of causation of depression and anxiety is the same: low serotonergic activity. Therefore, antidepressants such as SSRIs can be used in both depression and anxiety. Mood stabilizers, mania and bipolar disorder. Classic example is lithium. Anxiolytics and hypnotics. Anxiety and insomnia. Hypnotic means sleep-inducing medications. Classic examples: benzodiazepines. Brain stimulation therapies, they also cause neuromodulation, which is change in brain functioning, basically. ECT, which is used in severe depression or mania, treatment-resistant schizophrenia as well. Repetitive transcranial magnetic stimulation, depression, especially that which has failed one or more antidepressant trial. That means you're given SSRI for a good period of time, 6 months or more, but still the depression is not going away. Then you can try RTMS. Then there is MST, which is magnetic seizure therapy. So this combines the features of both RTMS and ECT. That is, just like in RTMS, stimulus is given electromagnetically, and just like in ECT, seizures are induced. But these seizures are focal rather than generalized, which is usually the case in ECT. So MST may be used after ECT, like a continuation therapy, because the cognitive side effects may be less in MST compared to ECT. But please remember that MST is still an experimental therapy and not being routinely used as ECT. VNS is vagus nerve stimulation, which is used again in resistant depression, just like RTMS. DBS, deep brain stimulation, last resort, absolutely the last resort in treatment-resistant OCD, very, very disabling, severe OCD, not responding to multiple medications, trials, then only go for DBS because it's pretty invasive therapy, Psychosurgery, obviously they are invasive surgeries. Ablation of pathogenic neural tissue. Neural tissue, brain tissue itself is removed. Whatever we think is causing the illness, okay? So only that particular area. For example, prefrontal lobotomy, olden days, crude therapy not being done. What happens if you remove somebody's prefrontal cortex? Dysexecutive syndrome, and their entire personality alters. They can become disinhibited. Gamma knife ablation, which is very, very specific, micro areas of brain can be ablated. Example again, just like DBS, resistant cases, highly resistant cases, highly disabling OCD, okay, like a last resort. Summary of psychological therapies: cognitive therapy, modifying the thoughts, or cognitive restructuring it is called, which is used in mild depression or anxiety. Behavioral therapies modify the behavior by using classical conditioning, operant conditioning, vicarious conditioning, and all those things. Example: systematic desensitization, replacing anxiety with relaxation. So there is relaxation therapy here in systematic desensitization at each successive stage of hierarchically arranged stimuli, either in vivo or virtual. In vivo means in the body, actually doing it. Virtual means VR, virtual reality. So what do? Spider arachnophobia, phobias, it's done mainly in phobias. Arachnophobia is classical example. So arrange the stimuli in ascending order. That means, lowest first, such as looking at a picture of a spider from a distance, for example. And the highest level will be holding a spider in the hand. So you go from one successive stimuli to other. And instead of being panicky or having anxiety, teach the patient to relax. It is okay to see the spider. It's not going to do anything. I'm going to relax. It's okay to hold the spider. I'm going to relax. So relaxation in hierarchically arranged stimuli. Exposure therapy, gradual exposure to stimulus. No relaxation. That is why I keep telling you about relaxation. In systematic desensitization, there is relaxation. Exposure therapy, no relaxation. Again, it can be in vivo or virtual. Phobias, again, indication. This is also gradual exposure to stimulus. Only difference is no relaxation technique as in systematic desensitization. Flooding, full intensity, go for the highest level of the stimulus. Again used as phobias, obviously no relaxation. In vivo or virtual, in vivo arachnophobia could be just putting the patient in the middle of spiders, so highest level of stimulus. Okay, or virtual could be, example, fear of flying, wearing the VR goggles and like sitting in a plane and the plane is having turbulence or something like that. Then you have token economies, which is like reinforcement or punishment using token as rewards, which is used in behavioral disorders, such as star charts. If you display good behavior on 5 days, you will get a star. And if you get 5 such stars, you can go out to the mall and buy whatever you like to eat, those sort of things. That is token economies. Aversion therapy, reducing undesirable behavior through actual noxious stimulus. So it is not imagination, it is actually noxious consequence, reducing an unwanted behavior. Used in addictions. Classic example for aversion therapy, disulfiram, also called antabuse. You take that drug, and if the person drinks, they are going to have a violent reaction. Aversive therapy for alcohol use disorders. Covert sensitization, reducing undesirable behavior through imagined noxious stimulus. So that's the difference between aversion therapy and covert sensitization. Covert means hidden, so it's all in imagination. Okay. Again, you can do it in addictions, behavioral disorders. If I keep gambling, I'll be arrested. So imagine being arrested. So that will act like a deterrent to gambling. That is an example. Biofeedback, altering involuntary physiological response to stimuli through sensory feedback. So you have biofeedback machines which can be attached to the body. And if each time the person feels stressful or something, such as anxiety disorders, the person can monitor the pulse, BP, and get himself or herself to be more conscious, relax, and all those things. Vicarious conditioning, learning through observing others' behavior. Classical conditioning or operant conditioning of behavior. Okay, and that is used to enhance interpersonal skills. You show them what the ideal behavior is and get them to do the same thing, and over a period of time, they learn that behavior, vicarious learning. Continuing with summary of psychological therapies, psychodynamic psychotherapy, it goes much deeper, as you know, resolution of symptoms through analysis of unconscious defense mechanisms, hypnosis, free associations, or you associate with certain words, for example, Freudian slips, making mistakes while speaking, dream interpretation, because dreams can be like unconscious wish fulfillment kind of expressions, and they are very abstract. So you have to analyze the dreams. Indications, phobias, anxiety, mild depression, mild personality issues, not for severe personality issues like antisocial personality disorder or something, because they won't be able to handle all the horrible things that can come out during therapy. They'll react very, very badly. Relationship difficulties or other indications for psychodynamic psychotherapy, and definite contraindication for psychodynamic psychotherapy is psychosis, because they're delusional. They can't handle the things that will come out during psychodynamic psychotherapy. Humanistic therapy, healing through empathy, unconditional positive regard, and reflective listening. So you actively listen to the patient's whatever patient is saying. Unconditional positive regard, that means no judgment. It is okay. Mistakes have happened, no problem. We can move forward. Empathize with the patient. That's used in anxiety, low self-esteem, and relationship difficulties. Group therapy, mental health professional leads the therapy with more than one recipient, okay, not just one patient. That will be like a supportive psychotherapy or something, or psychodynamic or CBT. This is group therapy, so you need more than one patient. So traditional group therapy addressing one issue in all group members through disclosure and feedback. Okay, so one issue is tackled in traditional group therapy, such as low self-esteem, anxiety, IPT, that is interpersonal skills. Family systems therapy and marital therapy, improving family dynamics through improved ways of responding to each other. That is used obviously in relationship difficulties. Self-help groups, on the other hand, there is no mental health professional there. Okay, so that's the difference. Voluntary groups run by recovered patients with common problems. Classic example is addictions, AA and NA, trauma and stressor related conditions. Post-traumatic stress disorder. Symptoms occur at any time after a traumatic event and lasts for more than 1 month. Very important. Any time after the traumatic event. Definitely lasts more than 1 month. Symptoms from all 4 groups must be present. And the 4 groups, IANA, to remember, mnemonic. That is, I means intrusion and dissociative symptoms such as flashbacks, nightmares. Flashbacks when awake, nightmares when asleep. And even dissociative symptoms such as unreal feelings, perhaps memory disturbances, all those things. Avoidance, that is, if it was an accident, not going to that road anymore. So that is avoiding. Not coming out of the house. Negative alterations in mood and cognition, nothing but depressive symptoms. And arousal and reactivity. Increased startled reflex, sleep disturbance. The person is so aroused that they cannot relax and fall asleep. All that is part of that. IANA, all 4, at least one from each of these should be present for more than 1 month, anytime after the traumatic event. And the trauma should be very, very traumatic for anybody who is faced with it. Acute stress disorder, same as PTSD. 9 or more PTSD symptoms are present. Only difference is it begins immediately after trauma, usually within hours and days. And it lasts anywhere from 3 days to 1 month. Very important. That's why it's so important. 3 days to 1 month only. Because it is self-resolving. Means it goes away even without treatment. Adjustment disorder, acculturation difficulties as we talked and all those things. It is also PTSD-like symptoms, okay? So the PTSD symptoms, IANA, may be common to PTSD, ASD, and adjustment disorder. Don't forget. PTSD-type symptoms within 3 months of the psychosocial stressor. Here the stressor is not accident or terrorist attack or sexual assault or something. It is more chronic, vague, like moving to a new country, getting divorced, getting retired, psychosocial stressors. Maladaptive behavior results in a few months after the stressor ends. So if the stressor goes away, adjustment disorder also goes away. If a retired person finds some part-time employment, for example, adjustment disorder that he was facing with also goes away. Not explained by any other condition. So this is a diagnosis of exclusion. Exclude all other conditions such as depression, anxiety, PTSD, ASD. Rule out all those things before you make a diagnosis of adjustment disorder. Because adjustment disorder may be associated with depressed mood, anxiety, or disturbed behavior. They are the subtypes. Adjustment disorder with depressed mood, adjustment disorder with anxiety, adjustment disorder with symptoms of disturbed behavior, which can also be violence, hitting, destroying properties, hitting others, and all those things. Reactive attachment disorder and disinhibited social engagement disorder, childhood conditions. Okay, PTSD, ASD, adjustment disorder, adult conditions. RAD, DSCD, childhood conditions. RAD, emotionally and socially withdrawn behavior by the child. Child has difficulty bonding with the caregiver. Onset within 5 years. It should not be due to autism or MR. In autism, there is a lot of withdrawal, not much social interaction. So it should not be secondary to autism. Emotionally withdrawn, socially withdrawn, no bonding with the caregiver. That is reactive attachment disorder. That's why it's called attachment, no attachment. DSCD is the opposite, excessive attachment, over familiar behavior even with strangers. Child has indiscriminate social behavior, such as walking away with a stranger. And this also leads to abnormalities in attachment, but it's not as severe as in RAD. Okay. Again, the onset should be less than 5 years, and it should not be secondary to ADHD, because remember, similar features. ADHD also, they can be very over familiar because they are so restless. They'll go and talk to everybody. They'll blur it out. Anxiety disorders. Under this, you have panic disorder. Recurrent sudden panic attacks with or without triggers for 1 or more than 1 month. So the trigger may or may not be present. Please remember, somebody may be sitting at home and still have a panic attack. But the attack should have happened for more than a month, associated with fear of having an attack and avoiding the trigger. So the anticipatory anxiety is there. That means they know that the panic attack may come at any time. And therefore, if it is a trigger-oriented panic attack, they'll try and avoid the trigger. Triggers help in determining the nature of anxiety, such as panic, phobias, generalized anxiety disorder. So in other words, what we are saying is, social anxiety disorder also has panic attacks. Phobias may also have panic attacks. Agoraphobia can also have panic attacks. But what is the trigger of the panic attack? You have to ask yourself that. In agoraphobia, you have definite triggers, which we'll be talking about. In social anxiety disorder, socializing is a trigger. So in specific phobias, the specific item, thing, situation is the trigger. So you ask yourself, what is the trigger? Because panic attacks may be common to all of these things. So agoraphobia, for example, persistent and excessive fear or panic attack as a response to 2 or more of the, and those triggers could be using public transportation, buses, trains, cars, planes, being in open spaces, desert, for example, being in enclosed spaces such as lift, standing in line or being in a crowd, being lost in a music festival, for example, being outside of the home alone, traveling alone, going out of the house, because the house is a safe zone for this patient. So going away from the house can trigger panic attacks. Okay, and that leads to fear and avoidance, because escape or rescue may be difficult if incapacitating or embarrassing symptoms develop. In the middle of a music festival, in the middle of a crowd, suddenly the person develops panic attack and they feel very embarrassed because they can't get out of the crowd in a hurry. They can't get out of the lift in a hurry. So escaping or being rescued by somebody else is difficult in these situations. That is the key phrase there. Escaping or rescue is difficult. Whereas social anxiety disorder, panic attacks or anxiety due to excessive fear of being in public or performing in public. Example, meeting new people, going on stage, eating in public, eating in a restaurant also can be traumatic for them. Fear of making a fool of oneself in public. They're always thinking that, what if things go wrong? What if people think that I'm an idiot? My weaknesses are exposed in front of others. So that is social anxiety disorder. Subtype could be performance only subtype. That means only when you ask the person to perform something, such as going on a stage, then there is anxiety. Otherwise, there is no anxiety. Specific phobias, fear of a single situation or object. Subtypes, animals, fear of spiders, for example. Natural environment, fear of forests, for example. Blood injection injury, needle phobia. Okay. Situational, going to somebody's house where something bad happened, for example. Being with somebody who had a terrible experience with any other thing. Okay, so that is specific phobia. Generalized anxiety disorder. Uncontrolled persistent anxiety or worry due to multiple triggers. There are many triggers here. That's why it's called free-floating anxiety in all situations, even at home. 3 or more of restlessness or being on the edge, fatigued, low concentration, irritability, muscle tension, and insomnia. Any of these 3 or more should be present. And again, like adjustment disorder, this is a diagnosis of exclusion. Rule out all the other conditions before considering GAD. 2 childhood conditions under anxiety disorder: separation anxiety disorder, excessive fear of separating from an attachment figure, such as parents, Classically happens when the child is about to go to school, lasting for more than a month, usually diagnosed between at 7 to 8 years. Selective mutism, refusal to speak in specific situations, again school, not speaking at school, but speaking very well at home, lasting for more than a month, usually around 5 to 6 years, but improves by 10 years. Absence of speech, remember, it should not be secondary to any developmental delay such as mental retardation or a communication disorder, the speech disorders that there are so many of, or autism, where speech is not developed. Okay, it should not be secondary to any of these. It should happen on its own. And it is situation specific. Only in somebody's house, only in school. That's why it's called selective mutism. And related to anxiety disorders are OCD and related disorders, obsessive compulsive disorder, presence of obsessions or compulsions or both. So please remember, any one is enough. It is still OCD. Just obsession is enough, it's still OCD. Just compulsive act is enough, it's still OCD, or both. That are time consuming and cause socio-occupational distress. Quality of life is affected. Examples of obsessions: recurrent intrusive thoughts, images, or impulses or urges that cause distress, and the patient tries to block unsuccessfully. Distressing thought keeps coming. Patient tries to block the thought and move forward, but he's unable to because it keeps coming. It's intrusive. Compulsions, physical or mental acts done to relieve the distress caused by the obsessions. For example, checking. The obsession could be, I don't think I've locked the house properly. So you go and check. You keep on checking. Okay? Counting. Something bad will happen if I don't count up to 25. So that could be the obsession that causes distress. Therefore, the person can count. Count through mouth or even mentally. Mentally counting 1, 2, 3, 4, 5. Even that is compulsion. Touching objects repeatedly. Washing hands. Classical example. Hands are contaminated. That is the obsession. That causes distress. And that leads to compulsive act, which is repeated hand washing. Rearranging. Things look very disorderly here. That is the obsession. That causes distress. To relieve the distress, rearrange. Keep on rearranging. Hoarding. Right? Accumulating things which you don't need. That is also an example of compulsions. If these anxiety type of obsession, if it progresses, it becomes fixed in intensity, it becomes delusional. So that becomes a psychotic subtype, which is with absent insight or delusional belief. This is what we mean by dimensional nature of these conditions. Okay, so that is a subtype of OCD. Body dysmorphic disorder, BDD, preoccupation with usually one single flaw in some physical appearance. Usually it is a facial feature, such as eyes are too wide apart or too close, nose is too broad, too flattened, too long, those sort of things. Leads to isolating self from others. Their confidence is affected, low self-esteem. Subtype, again, if this belief becomes of delusional intensity, then you call it BDD with absent insight or delusional belief. So it becomes a delusional disorder then. BDD becomes a delusional disorder. Again, the dimensional nature of these conditions. Hoarding disorder, compulsive accumulation of unwanted items or possessions that the person may never use. I'm going to keep all these cartons. I may not use them in the near future, but what if I have to? So I'll accumulate hundreds of cartons. And it can be rubbish also sometimes. Okay, so that is hoarding disorder. It is a type of compulsion, subtype of compulsion. Excoriation disorder, compulsive picking of skin leading to wounds. Picking the skin repeatedly, not because it's itching or something. Okay, so rule out organic conditions like skin condition, eczema, for example, which causes itching. So it's not because of that. And also rule out BDD, body dysmorphic disorder. They should not be scratching at a nose, for example, trying to thin it down because they think the nose is too fat, too broad. Okay, so it should not be secondary to that. It is a compulsive subtype of compulsion. They feel better if they keep doing it. Okay. Trichotillomania, compulsive hair pulling leading to patchy hair loss, pulling the hair. Again, rule out skin conditions, itchy scalp or something. or organic conditions. If somebody is using, for example, anti-cancer chemotherapy, that also leads to hair loss. That should not be secondary to any of those. Depressive disorders, major depressive disorder or episode, MDD or MDA. Please remember, MDA is one episode. Okay, several episodes will cause a disorder. Just like one panic attack is an attack, several panic attacks is a panic disorder. So you need at least 2 weeks. 2 weeks, magic number, you have to remember. 5 or more of the following symptoms, out of which one or two should be present. That is, depressed mood should be present, or anhedonia, loss of interest in previously enjoyed activities, should be present. Then other features such as significant weight change, insomnia or hypersomnia, sleep loss or excessive sleep, loss of energy, energia, psychomotor changes such as psychomotor retardation, feeling guilty or worthless, thoughts of death or suicidal ideation, decreased concentration. So 5 or more of these should be present. Mood fluctuates between major depressive episodes and euthymia. Episodes last less than 2 years, because if it goes beyond 2 years, it is PDD, persistent depressive disorder. 6 subtypes of depressive disorders, atypical features with atypical features, such as reversed biological features, such as weight gain, eating more, sleeping more, those sort of things. Catatonia, catatonia of abnormal postures and all those things. It could be that. Melancholia, extreme depressive features, extreme sadness. Psychotic symptoms, severe depression with mood congruent delusions, such as the body is rotting, I am already dead, those sort of things. Peripartum onset, that is after delivery, postnatal depression and all those things. Or it could be before delivery also. That's why it's called peri, which means around delivery. Seasonal pattern, feeling depressed during winters because it becomes darker much earlier than in summer. Okay, seasonal affective disorder, but now it's called major depressive disorder, seasonal pattern. Okay, persistent depressive disorder, chronic depression of 2 or more years with no remission. Could be persistent major depressive disorder itself can persist for more than 2 years, or it could be dysthymia. That means chronic low mood, not severe enough to call MDE. Or it could be both. Sometimes it is dysthymia and sometimes it is MDD, but lasting for more than 2 years. Premenstrual dysphoric disorder, PMDD, dysphoric symptoms 1 week before the menstruation to a few days after. It's self-limiting, but it can cause mood ability, changes in mood, irritability, and anxiety. So it can be 1 week before to a few days after menstrual period, but it's self-limiting. Disruptive mood dysregulation disorder, childhood condition, severe temper outbursts, three or more episodes per week in a child. Symptoms develop at 6 to 10 years of age, not diagnosed after 18 years of age. So it is exclusively childhood or developmental condition. And it is a mood disorder. That's why it is included in the DMDD. Temper outbursts. Suicide, if somebody is extremely depressed, they can have suicidal ideas. So risk factors. Health-related depression itself is a major risk factor. Schizophrenia, 1 in 10 schizophrenics commit suicide. Eating disorders, overall rate is 20%, I think, 20 to 25%, very, very high rate. Substance use, alcohol, cannabis, cocaine, increase the risk of suicide, okay? Cancer, especially stage 4 cancer, end stage cancer, where there is no hope, increases the risk of suicide. AIDS, progressive AIDS, okay? Full-blown AIDS, again, loss of hope leads to loss of suicidal ideas. Contextual also, depending on the context, family history could be there, so that increases the suicide risk. Access to lethal means, such as access to firearms. That's why it's very common among military personnel or police. Loss, any kind of loss, relationship loss, divorce. Financial, major risk factor for suicide in all cultures, especially in India. Look at any suicide news, probably due to debt, mortgage, not being able to pay back finances. Job loss also can be a trigger for suicide. Victims of bullying or abuse, right? Teenage children going to college being bullied. Many have committed suicide. Abuse, And one more loss, exam results, failing in exams. Every time we have 10th or plus 2 exam results, in psychiatry, it's taken for granted that the suicide rates will be higher because, teenagers, children who fail exam, unfortunately, they do commit suicide. Management, evaluate the risk factors, above factors. Suicidal intent, very important, and support systems. You can use rating scales to look at the suicide intent as well, okay? In fact, it's called suicide intent scale. Support systems, is the family there to look after, or they're living alone, and all those things. So based on that, you come up with an action plan. If it is low risk, it could be OPD psychotherapy. They can go and come back to the OPD. Consider antidepressants if there is depression. Moderate risk as above, that is OPD and antidepressants, plus create a safety plan. So safety plan such as who is to look after, family responsibilities, community, nurse, for example, social work, what is to be done in times of crisis, all those things. Severe risk, when in doubt, just hospitalize. So severe risk, hospitalize. If you feel there is a significant risk to self, it's not just risk to others, it could be risk to self as well. And suicide is a classic example of risk to self, then please admit involuntarily as well. Observations, you designate one staff member to continually observe the patient. Of course, antidepressants, ECT, if it is very, very severe. Antidepressant medications, what do? They inhibit reuptake of neurotransmitters, but they can also inhibit degrading enzymes of monoamines. They are used in both anxiety and depression. And the monoamines that of interest as far as antidepressants are concerned is 5-HT, which is serotonin, norepinephrine, and dopamine also to a certain extent. SSRIs, they inhibit the reuptake of serotonin. Therefore, they increase serotonin levels. Fluoxetine, sertraline, escitalopram, examples. They can cause GI distress, nausea, vomiting, and also sexual dysfunction. SNRIs, serotonin, noradrenaline reuptake inhibitors. So they inhibit the reuptake of both serotonin and noradrenaline. Venlafaxine and duloxetine are examples. Again, GI distress and sexual dysfunction. Tricyclic antidepressants inhibit reuptake of serotonin and noradrenaline. Amitriptyline, imipramine, dethiapine are examples. ECG changes. Sudden cardiac death can also occur. Weight gain, there are so many. Drowsiness also is a problem. MAOI, monoamine oxidase inhibitors, they inhibit the degrading enzyme. So monoamine oxidase is inhibited. Therefore, they increase level of serotonin, noradrenaline, and dopamine. Phenelzine, moclobamide, and phenylcypromine are the examples. They can cause BP changes and cheese reaction. Cheese means basically tyramine containing food substances are to be avoided if somebody is taking MAOIs because they can cause a reaction with the tyramine because monoamine oxidase enzyme is being inhibited. Therefore, tyramine is not being dealt with appropriately. And that can cause sudden collapse in BP and it can be fatal also. So I have to be very, very careful. We have to give them a list of food substances that they cannot take, tyramine containing food substances. Bipolar disorders. Under this, you have bipolar 1 and 2, right? So you have to know about manic episode. So manic episode means abnormally elevated mood or irritability, okay? Happiness or irritability, plus increased energy or activity. Any of these, plus any three. So happiness or irritability has to be present along with high energy or high activity. Okay, both have to be present. Plus any three of inflated self-esteem or grandiosity, such as I am rich, decreased need for sleep, pressured speech, flight of ideas and or racing thoughts. One theme of idea leads to another. Today the weather is very hot. It is very sunny. Sun can cause skin damage. Skin damage leads to cancer, flight of ideas. Distractibility, excessive involvement in risky activities such as overspending, driving rashly, or even sexual disinhibition also, leading to unwanted pregnancies. Increased goal-directed activity or psychomotor agitation such as purposeless activity. Building a stool, for example, when you have so many seats in the house and the wife will say, why are you doing this? But the patient has that need to keep doing it because there is high energy and increased activity. Symptoms should last 1 or more than a week, or in depression it is 2 weeks, whereas in mania is 1 week, 1 or more week, or any degree duration of hospitalization, even 1 day of hospitalization. Associated with marked socio-occupational disruption. Very, very, very important to distinguish between this and hypomania. And of course, psychotic symptoms may or may not be present, such as delusions and hallucinations, grandiose delusions usually. Socio-economic occupational disruption means not being able to work, and can't maintain relationships also as well. Hypomanic episode, as above, all the features could be present, but not 1 week, 4 days. 4 or more days. Hospitalization usually not present at all. Okay. Do not cause socio-occupational disruption. That means they can still maintain the job, still have good relationships. No delusions, no hallucinations, no hospitalization. Difference between mania and hypomania. So bipolar 1 disorder, therefore, mania is always present with or without major depressive episodes. They are usually present, but not always necessary to make a diagnosis of bipolar 1 disorder. So in other words, just one manic episode is enough to make a diagnosis of bipolar 1 disorder. Understood? Bipolar 2 disorder, 2. So you need both. That is, hypomania always present and major depressive episode always present. You need both. Hypomania and MDEs. That is bipolar 2 disorder. Cyclothymia, just like dysthymia, alternating hypomania and dysthymia, lasting for 2 or more years. So this is the pictorial representation. So this here is normal or euthymic mood. That is the baseline mood. Higher than that is hypomania. Highest is mania. Below, one step below is dysthymia. And the lowest is major depressive episode. So depression is reaching the depressive phase, but less than 2 years. That is MDD. PDD, it is depressive stage, but it is for more than 2 years. All of these are more than 2 years. That's why it's PDD. Or it could only be dysthymia, but lasting for more than 2 years. Therefore, it is PDD. Or it could be alternating dysthymia and depression, and each of these episodes, or the overall episode, is more than 2 years. Therefore, it is PDD, the 3 types of PDD. Bipolar 1 disorder, the mood is going from normal to manic, highest level. Interrupted lines below euthymia because MDE may or may not be present. Bipolar 2 disorder, there is definitely hypomania, okay, and definitely major depressive episodes, not interrupted lines. Both have to be present. Cyclothymia, again, just like PDD, episodes more than 2 or more than 2 years, and it alternates between hypomania and dysthymia. Let's look at mood stabilizers. Primary purpose of all mood stabilizers is bipolar disorder, right? Mechanism we don't really know. Okay, neurotransmitter also we don't really know. So the first line mood stabilizer, first choice, drug of first choice is lithium always. Side effects, thyroid toxicity, renal toxicity, kidneys are affected. Water retention, remember it is exclusively excreted in kidney. It is a cation, exists as Li plus in the blood, therefore it is exchanged in the kidneys, therefore it can cause renal toxicity and water retention. No first pass metabolism in the liver, therefore it does not affect the liver. It can cause tremors, teratogenic effects, that is, if a pregnant woman takes it, especially during the first trimester, it can cause cardiac defects in the newborn. What is that called for lithium? Epstein's anomaly, yeah, cardiac defect. And lithium toxicity, if it goes beyond 1.2 milliequivalents per liter serum level, it can cause toxic features such as drowsiness, increased tremors, renal failure, and can also be fatal. So you have to be very careful. You have to do hemodialysis if it goes into toxicity. Second line, if lithium contraindication is there, such as severe renal disease or severe thyroid disease or whatever, or if there is some toxicity, then you go for second line, such as sodium valproate, which is a broad spectrum anti-epileptic medication also. Here it is definitely metabolized in the liver, therefore liver toxicity is seen. Weight gain can occur, hair loss is seen, and teratogenic effects. Same like lithium, if taken during first trimester, it can cause open neural tube defects, such as spina bifida and all those things. So you have to be very careful. Again, carbamazepine is after sodium valproate. It is also metabolized in liver, therefore can cause liver toxicity and teratogenic effects, similar as sodium valproate, open neural tube defects. Third line would be the other anti-epileptics, such as gabapentin and topiramate. So second line onwards, they're all anti-epileptics, which are also mood stabilizers. Somatic symptom and related disorders. Somatic symptom disorder, also known as somatization in the olden days. Soma means body, okay, and psyche means mind. So here, whatever affects the psyche presents itself in the soma. So excessive preoccupation with one or more significant bodily symptom. They may be feeling stressful, but it is manifesting more as a bodily symptom, such as aches, pains, headaches, burning sensation in the epigastrium, burning micturition, sexual dysfunctions, any of these. But one or two of these symptoms may have a medical basis. Like, for example, they could have migraine, which is a cause for headache. But the preoccupation with that symptom is very, very severe, more than what is expected. Okay, so preoccupation with bodily symptoms, one or more symptom, with no underlying cause. One or two of the symptoms may have a medical basis. Related condition is illness anxiety disorder, and in the olden days we used to call it hypochondriasis. So basically it is excessive worry about major underlying illness without significant symptom and no medical basis for anxiety. Please note the difference between SSD and IAD. In SSD it is symptoms, whereas in IAD, it is major underlying illness, diagnosis, one particular diagnosis they're concerned about, such as cancer, AIDS, brain tumor, something like that. No symptoms, they are just preoccupied with having the illness. And also they will undergo multiple investigations and no medical basis is found for this anxiety, okay? And again, dimensional nature, this may, if the anxiety becomes firm and fixed, it can become delusional, and then you call it hypochondriacal delusion. So what is like a anxiety disorder can change into a psychotic condition. Then you have conversion disorder, which is neurological symptoms, but functional. That means there is no organic basis to it. And medically incompatible. Again, if you do investigations, there is nothing found. Everything is normal. And usually sudden onset, there may or may not be a trigger for these neurological symptoms. Good news is it is short-lived, that is, it can go away. So typically after traumatic events such as somebody dying in the family, somebody announcing separation all of a sudden, something like that. And symptoms are usually neurological, such as fainting, loss of sensation in the body, some part of the body, loss of muscle function in the limb, pseudo seizures, going blind also can also happen. Factitious disorder and malingering, better to kind of consider them together. Factitious disorder in olden days was also known as Munchausen syndrome, but now we just call it factitious disorder. Factitious disorder is falsification of symptoms due to a primary gain. Primary gain means there is no external reward. Even the patient does not understand why he or she is doing it. Okay, it could be to assume a sick role. They enjoy the attention that they get by assuming a sick role. But it is not like some kind of external reward, like getting compensation or escaping punishment or whatever. Malingering is again falsification of symptoms due to a secondary gain, okay, external reward. Example, prisoners trying to escape punishment or accident victims trying to get more compensation. So they falsify symptoms, they exaggerate the symptoms, okay. Factitious disorder can be imposed upon a dependent minor, such as a parent upon a child, in which case it is known as factitious disorder by proxy. And of course, malingering by proxy can also happen. Moving on to dissociative amnesia, amnesia for which there is no organic basis, okay, memory loss for autobiographical information not caused due to any other condition, not brain injury, not some medical condition like encephalitis, meningitis, whatever, is not causing the memory loss, and not dementia either. So it is not due to any other cause. So it could be localized memory loss in dissociative amnesia, where total loss of personal memory during a circumscribed time period. The yellow part is memory loss. But other than that, memory is okay. So only one confined period. Selective or patchy memory loss, some limited recall of personal memories during a circumscribed time period. So there is a bit of memory loss here. When the memory is regained, then again there is memory loss. So it is patchy, not continuous. Okay. Generalized memory loss, loss of personal memory for entire life, including the trigger event. Okay, so there is no blue areas indicating memory at all. It's all yellow, loss of memory. Okay, so that is generalized memory loss. These are the three subtypes of dissociative amnesia. So accordingly, based on all of that, dissociative amnesia, basically it just means autobiographical memory. That is, personal information is lost by the patient, and it could be localized, selective, or generalized, as we just saw. Dissociative amnesia may be associated with fugue. Fugue means traveling away, that is of sudden onset, but it recovers spontaneously. So the person loses memory about himself and wanders about aimlessly, can end up in a different town altogether. Then suddenly when it passes, he will come to and he will struggle to understand how he got there. So that is a typical description of fugue. Dissociative identity disorder, also known as multiple personality disorder. There is amnesia. Amnesia is a recurring theme in all of these. But there is personality alteration. That means interacting with the environment with two or more personalities. Primary personality, which is the patient's own, associated with at least one alternative personality, alters. Okay. If it is a man, he or he may act as a woman sometimes. Or if it is a young man, he may act like an old man. So likewise, the personality changes, even the voice changes. So one personality does not know that the other personality is active. So that's how it works. That is dissociative identity disorder. Then you have depersonalization disorder, wherein there is misperception of or being distanced from one's mind or body. So alteration in shape, form, or color of one's own body. Everything might appear vague mentally. Derealization is the environment is changing. Misperception or changed environment. Surroundings being altered in shape, form, or color. The people might appear smaller. The trees might appear redder instead of green. Distances may appear very far away or too close. All these things could happen. Depersonalization, derealization could also occur as psychological features of extreme panic attacks, but it is under DSM-5, it is included as dissociative disorders, and any one of them is enough to call it DDD, that is depersonalization, derealization disorder. Psychotic conditions, schizophrenia. One or more than 1 month of active phase, very important. And during the active phase, one of the three core symptoms has to be present. And the core symptoms are delusions, hallucinations, and disorganized speech, which is reflective of disorganized thought disorder. Okay. Plus at least one of disorganized or catatonic behavior and negative symptoms. Negative symptoms means alogia, energia, anhedonia, and flat affect. Okay, all the things beginning with A. So any one of those, but at least one of the three core symptoms have to be present. Total duration of illness in schizophrenia, 6 or more months have to be present. And during those 6 or more months, there will be a prodromal stage, which means before the acute phase, and active phase, as we have mentioned, 1 or more than 1 month, characterized by all those symptoms. And residual phase, which means after the passage of the active phase. Okay. Totally, it should be 6 or more months. Then you have schizophreniform disorder, which is the duration is less, that is 1 or more month, but less than 6 months. And you need 2 or more active phase symptoms, out of which one of 3 core symptoms have to be present. So basically very similar to schizophrenia except for the duration. It is less than 6 months. Brief psychotic disorder, as the name suggests, is very brief. It is less than a month. So it can be one or more than 1 day, but less than 1 month. And you don't need 2 active phase symptoms, you just need 1. Even 1 is enough, 1 or more active phase symptoms. And of course, one of 3 core symptoms have to be present. But the key difference between schizophreniform disorder on the one hand and brief psychotic disorder is that there is full recovery in brief psychotic disorder. Less than a month, 1 active phase symptom and full recovery in brief psychotic disorder. Delusional disorder, 1 or more than 1 month of delusion and no other psychotic symptom, very important. That means no hallucinations, no disorganized speech, no negative symptoms, no catatonic behavior, just the delusional belief. When you need 1 or more than 1 month, okay? And there are so many types of delusions, as you know, Cotard syndrome, Capgras syndrome, erotomania, grandiose delusions. So many are there. Schizoaffective disorder, as the name indicates, schizophrenic symptoms are coinciding with affective symptoms or mood symptoms. So concurrent psychosis and mood symptoms. Mood symptoms may be mania or depression, plus psychosis alone. So there should be a phase, active phase symptoms of 2 or more than 2 weeks, as in schizophrenia. That has to be present. That means there should be a phase of illness without mood symptoms and only psychotic symptoms, plus mood symptoms during majority of the total illness duration. Suppose the illness is for 9 months, 6, 7, 8 months should have mood symptoms, but there should also be a period without mood symptoms during which psychotic symptoms are present. So all 3 criteria have to be met in schizoaffective disorder. Subtype schizoaffective disorder, bipolar type, if it is a manic episode that is coinciding with schizophrenia, or schizoaffective disorder, depressive type, if there is only depressive symptoms along with psychotic symptoms. So to illustrate this further, this example is there. Patient concurrently psychotic and depressed for 6 months. Depression resolves, psychosis remains for 3 months. So the total illness duration right there at the bottom is 9 months. Okay. So the first question that you have to ask yourself is there concurrent mood and psychotic symptoms? Yes, because the yellow is psychotic behavior, green is mood symptoms, both are present, at least for 6 months. The second question is psychotic symptoms alone without any mood symptoms? Yes, because there's nothing here in green. So psychotic symptoms for 3 months at least is present. So the second criteria is also met. Third question you have to ask, relative proportional duration of psychotic symptoms to mood symptoms. That means majority of these 9 months are mood symptoms present. So out of 9, 6 months has green, that is mood symptoms. So that criteria is also met. So you need all 3 to call it schizoaffective disorder. So before we go on to the antipsychotic medications, let's have a look at the dopamine pathways in the brain. The picture on the right has all those arrows there in the middle, and that's color coordinated according to the color of the letters on the left. So the mesolimbic pathway is in blue, mesocortical pathway in red, nigrostriatal pathway in green, and tuberoinfundibular pathway in orange. And that's how the pathways appear in the brain as shown in that picture on the right. So the mesolimbic pathway is responsible for positive symptoms, and it has projections from ventral tegmental area to nucleus accumbens and is involved in reward, reinforcement, motivation, and motor function. So remember what we said about positive symptoms earlier. It's all the things that you can see in the patient during the mental state examination, such as delusions and hallucinations. So now I'll move on to mesocortical pathway given in red, and that is responsible for the negative symptoms. So this has projections from VTA to DLPFC, that is dorsolateral prefrontal cortex, and that's responsible for the executive functions, that is initiating and inhibiting movements, planning a sequence of action and all that, which is a frontal lobe feature. And projections also from VTA to VMPFC, that is ventromedial prefrontal cortex. And this is responsible for emotions and affect. And as you know, in negative symptoms, there are a lot of emotional changes, right? Such as isolating self, anhedonia, not speaking a lot, etiology, energy, and all those things. So that occurs due to the involvement of the mesocortical pathway. So in the nigrostriatal pathway, shown there in the green, if that is involved due to the antipsychotic effect, then you can have extrapyramidal side effects. So projections from substantia nigra to striatum, that is caudate and putamen, this is responsible for stimulation of purposeful movement. Therefore, there is muscle changes such as rigidities and tremors, which are seen in extrapyramidal side effects, which occurs due to antipsychotic action on this pathway. Lastly, tuberoinfundibular pathway is responsible for prolactin release. It has projections from the hypothalamus to the infundibular region. Normally, it inhibits prolactin release. So by giving antipsychotics, you're removing this inhibition, okay? And therefore, prolactin is released more. Therefore, a classic example is something like risperidone. If given, it almost always causes an increase in prolactin level by removing this inhibition by the tuberoinfundibular pathway. So that leads to the consequences of hyperprolactinemia, such as galactorrhea, painful breast engorgement, and infertility in both the genders. So this is briefly about the dopamine pathways in the brain. A word about the antipsychotic medications. First generation is also called typical antipsychotics. Examples, thorazine, chlorpromazine, which was the first antipsychotic to be discovered, and haloperidol, a very famous example. That's why it's highlighted. They are called typical antipsychotics because they act on the dopaminergic receptors primarily. Okay, so they are dopamine antagonists. They reduce the dopamine levels, and therefore they help reduce the positive symptoms. Side effects would include extrapyramidal side effects due to blockage of nigrostriatal dopamine and ECG changes. So you have to be very careful. Second generation or atypical antipsychotics, example clozapine, which is used in treatment-resistant schizophrenia, and risperidone, very common example, commonly used. They are called atypical antipsychotics because apart from acting on dopamine receptor system, they also act on serotonin. They are also serotonin antagonists. That's why they are called atypical. So they help reduce both positive and negative symptoms. That is the advantage. Side effects, less CPSC, but they can cause agranulocytosis, affect the WBCs, especially clozapine, metabolic syndrome such as weight gain and all that, and hyperprolactinemia, increased prolactin levels leading to infertility and breast engorgement and all that, which is a particular problem with risperidone. So you have to be very careful about all that. This is personality disorder. 3 clusters, right? Cluster A, B, C in DSM-5, not recognized terminologies, but just for your remembrance. Cluster A, also called mad or weird conditions. Cluster B, bad or wild conditions. Cluster C, sad or barriers. Okay. So under cluster A, you have paranoid, schizoid, and schizotypal. Paranoid personality disorder characterized by accusatory behavior, distrust, and general suspiciousness. Differential diagnosis, delusional disorder, persecutory type, which we'll look at later on. Schizoid personality disorder, they are very aloof. They prefer to be aloof, and interpersonal detachment. They don't want to meet people. Differential diagnosis, social anxiety disorder, avoidant personality disorder. Schizotypal, they are very awkward, they are eccentric, and they have magical thinking. It could be a pre-morbid personality of schizophrenia, like in the prodromal stage, like a precursor of the acute phase. So that could be schizotypal. Then in cluster B, you have 4 types. One of them is histrionic, where they are very bright and flamboyant, always ebullient, jolly, smiling, laughing inappropriately. Increased emotionality, emotional lability is seen, 1 minute crying, 1 minute laughing. Seductive behavior, that is dressing very, very provocatively, more common among women. The next one is borderline type, where it's called borderline because they are in the borderline of neurosis and psychosis, basically. And the theme here is an instability. They are very unstable beings. They take offense very easily. They have dichotomous thinking. That means the whole world is bad or good. Or even with a partner, they idolize at one time. And if the partner says no to something, they'll think he's the worst person ever. And they are prone to self-harming behavior, superficial cutting, self-harm, often without any intention of dying, either self-harm or threatening to self-harm. they may also have brief psychotic spells, such as hallucinations or something, and brief dissociative spells, such as memory loss and all that. More common among women again, and dialectical behavior therapy is a specific therapy that is done only in borderline personality disorder. Next is narcissistic personality disorder. They have a constant need to be the best in everything and generalized grandiosity. They think very highly of themselves and they disregard others' feelings. They feel that the others are there to serve them, basically, because they feel very grand about themselves. So obviously the differential diagnosis would be delusional disorder, grandiose type, and bipolar 1 disorder, because mania is present and mania is characterized by grandiose delusions, isn't it? Then antisocial personality disorder, they can be bullies, they disregard for others' rights, no empathy or no remorse. Lastly, in cluster C, personality disorders, you have avoidant personality disorder, where you have cowardly behavior. They have an inferiority complex which prevents them from going out and seeking friendships. Again, the differential diagnosis could be social anxiety disorder and schizoid personality disorder. You can do CBT, that would be the primary therapy. And an adjunct to that could be SSRIs can be used because there is a lot of anxiety in avoidant personality disorder. Dependent personality disorder, that they can be very clingy. They need somebody to cling on to, like an authority figure. They have an excessive need to be cared for, to be looked after. They give away responsibility to somebody else. And they feel very vulnerable if that person leaves. And they immediately find another person that they can become dependent on. Okay. So again, CBT can be done to increase the self-esteem and confidence and all those things. OCPD, or obsessive compulsive personality disorder, they have an excessive need to control everything. They are very pedantic. That means they follow minute rules and regulations with great detail and attention. Inflexible perfectionism. They want everything to be perfect. They don't understand that the world and people can be chaotic and disorderly. They become very upset and angry as a result. And of course, the differential diagnosis for OCPD is OCD, but we'll look at all the differential diagnoses now. So first, let's consider paranoid or persecutory type of delusional disorder and paranoid personality disorder. So the paranoia in delusional disorder, the thought is believed with certainty, and that is the only psychopathology that is present. No hallucinations, no catatonic behavior, whatever. Just the paranoid delusional behavior that somebody is trying to harm them. Okay. Whereas in paranoid personality disorder, the thought is merely suspected. It is general paranoia. They are suspecting everybody or every situation. And it's not of delusional intensity. Okay. If you tell them that actually that person is very good, I don't think he's trying to harm you in any way, they might still believe you. So it is not a delusional intensity. And the onset and course in delusional disorder, usually the onset is sudden. It could be in the Middle Ages. And like I said, the focus is on a single paranoid theme and nothing else. Whereas in paranoid personality disorder, onset is gradual. There's a developmental condition and there is pervasive paranoia. That means paranoid ideas about everything and everybody in all situations. Differences between OCD and OCPD. Clinically, OCDs are characterized by two things, that is obsessions, repetitive thoughts, measures or impulses, and compulsion, repetitive acts. Obsessions cause distress, and to relieve the distress, the person carries out compulsive acts. Either one of them can be present and it is still OCD. Whereas in OCPD, it is characterized by excessive perfectionism and control. They don't do any acts per se, and they don't have any recurrent intrusive thoughts per se, but they just want to control everything and they are perfectionists. Anxiety in OCD, they do have increased anxiety and they may also have panic attacks. OCPD, very minimal anxiety. They only get stressed out or angry if somebody is doing something which is not according to their own rules and regulations. Then you have the three things: delusional disorder, that is grandiose delusional disorder, and bipolar 1 disorder or mania. Narcissistic personality disorder. Clinical features: if it is a grandiose delusional disorder, it's just a single thing of delusional proportion. No other psychopathology is there. But if it is part of mania, there are a lot more symptoms such as reduced sleep, pressure of speech, flight of ideas, increased energy, with or without depressive episodes. Bipolar 1, remember, even mania is enough to call it bipolar 1. Whereas narcissistic personality disorder is general arrogance. They generally feel too high of themselves. Pervasive, it's present everywhere. Onset and course, onset may be sudden, like in any other delusional disorder, for grandiose delusional disorder, older age of onset, and single grandiose thing. Bipolar 1 disorder, onset may be sudden, usually manic attack comes on very suddenly, and it is relapsing. Mania by nature is relapsing and can alternate between mania and depression, although depression may not occur at all. It can just be several manic episodes. Narcissistic personality disorder onset is gradual and insidious. It is maybe present from childhood, and like I said, it is pervasive grandiosity that is present in all situations and towards everybody. Finally, the differences between these three things: social anxiety disorder, avoidant personality disorder, and schizoid personality disorder. Relations in social anxiety disorder, the person desires a relationship, but they fear rejection. They fear making a fool out of themselves. What if the other person does not like me? What if I look like an idiot in front of the other person? So that is the underlying theme in social anxiety disorder. Avoidant personality disorder, they do desire a relationship, but they are inhibited. They don't know how to approach. They avoid going out and approaching people. Schizoid personality disorder, unlike these two, they have no desire for relationship at all. They're very, very comfortable being by themselves. Anxiety in social anxiety disorder, obviously it's an anxiety disorder. Therefore, you have high level of physiological arousal such as heavy pulse, BP, sweating, breathlessness, may be associated with panic attacks as well. Avoidant personality disorder, there is some degree of anxiety, but not as extreme as in social anxiety disorder. Schizoid personality disorder people, they're not anxious. They like to be on their own, and if they are on their own, they do not experience any anxiety. Substance use disorder, general criteria for all substances, general dependence criteria, a maladaptive pattern of substance use manifested by 2 or more of 11 symptoms within the last 12 months. Very important, not remote, but last 12 months. So if to make it easy, you have to divide it into various headings such as impaired control, pharmacological or physical features, social impairment, and risky use. But it is counted all together, that is 1 to 11, and you need 2 or more of these. Substance is taken in larger amount than intended. Persistent, unsuccessful attempts to reduce substance intake is seen. Excessive times taken to obtain use or recover from substance use. Cravings or strong desire for taking the substance. Then tolerance, need to take more and more to get the same effect, or withdrawal symptom upon stopping the substance. Failure to fulfill major role obligations such as work, school, home, social or interpersonal problems related to the substance. It should be a direct consequence of taking the substance, such as wife becoming angry because the husband is drinking every day, for example. Reduction of important activities such as neglecting work and hobbies. Use in physically hazardous substances, which leads to disinhibition or risk-taking behavior, such as drunk driving, for example. Use despite having a physical or psychological problem related to the substance. The substance or alcohol, for example, is causing liver disease or pancreatic disease. It is causing depression. Yet the person continues to use, even though he knows that it is causing these problems. So those 2 or more symptoms could be from any one of these 11 symptoms. Individual substances, sedative or CNS depressants, you have 3 under those, that is alcohol, benzodiazepines, and barbiturates. So obviously the intoxication features for these would be sedation. Okay, so the keywords are highlighted in red. Sleepiness, decreased anxiety, disinhibition, impaired judgment, slurred speech and incoordination, stupor or coma in extreme cases, respiratory depression. Overdose is fatal, and of course, respiratory depression itself can cause fatality. Withdrawal features, opposite of what happens during intoxication. That is, you might have anxiety and insomnia, which makes it very similar to panic attacks. Hand tremors, extreme tachycardia or hypertension, delirium, especially in alcohol, it is called delirium tremens. Hallucinations, also known as formication, feeling as though bugs are crawling under the skin, which is known as tactile hallucination, and of course seizures. Major stimulants or CNS activators include amphetamines and cocaine. Intoxication features are divided into psychological and physical. Under psychological features, you have euphoria, grandiosity, psychomotor agitation or exhilaration, which is similar to mania, like a manic episode. You can also have stereotypies, paranoia, and hallucinations again, formication. Physical intoxication features for major stimulants, mydriasis or pupillary dilatation, elevated pulse and BP, appetite loss, insomnia, increased energy, and seizures. Withdrawal features, dysphoric mood, hypersomnia, nightmares, increased appetite. Dysphoric mood is similar to having atypical depression. Increased appetite is also sleeping more. That is also part of atypical depression. And these symptoms are usually not life-threatening. Minor stimulants are caffeine and nicotine, which is present in cigarettes, as you know, tobacco products. Increased energy and alertness. So major causes manic-like symptoms. So minor stimulants cause hypomania-like symptoms. Nervousness, anxiety, tachycardia, racing thoughts and restlessness, decreased appetite. Withdrawal features, dysphoria, irritability, fatigue, headache, decreased attention, insomnia, and increased appetite. Hallucinogens are three: LSD, mescaline, and psilocybin, also known as magic mushrooms. Intoxication features are heightened or altered sensory perceptions. So red color may appear redder, for example. And dissociative features are seen, such as depersonalization or derealization features. Hallucinations, visual or echoic, like hearing echoes, which are not there. Sense of well-being and sedation is there upon taking the substance. Paranoia and anxiety, which are part of what is known as bad trip. Some people may feel bad after taking the substance. There are no withdrawal features for hallucinogens. Cannabis, perceptual intensification, once again, sounds may appear much louder, for example. Conjunctival reddening or red eyes, increased appetite and dry mouth. Withdrawal features, irritability, nervousness, and dysphoria. Insomnia and reduced appetite. So increased appetite in intoxication, reduced appetite in withdrawal. Headaches, night sweats, and stomach cramps. Phencyclidine or PCP, also called dissociative anesthetic agents. Ketamine is one more substance, and dextromethorphan, which is present in cough syrup, even that is dissociative substance. So you have agitated, unpredictable, potentially violent behavior if a person is intoxicated. Nystagmus, rigidity, and seizures. Hyperacusis, that means hearing more, auditory perception is enhanced. Unresponsiveness to pain, and acute intoxication is a medical emergency, which you have to treat by giving benzodiazepines, for example. And withdrawal features, there are none. Opioids or opiates, in common terminology, also known as narcotics. Heroin and morphine are the common examples. Intoxication can cause analgesia, euphoria, drowsiness, and unconsciousness. Meiosis or pupillary constriction. Respiratory depression and overdose is fatal. Withdrawal features include nausea and vomiting, muscle aches, fever, and shivering, all of which appears to be very much like flu-like symptoms. Yawning, lacrimation, rhinorrhea, or running nose. Lacrimation means increased tears. Not life-threatening, but they are very uncomfortable. Treatment of some substance use disorder, the important ones. Nicotine, you have nicotine replacement therapy or NRT. You can give nicotine gums, patches, or lozenges, which is having low concentration of nicotine. Therefore, the craving is reduced. Anti-craving medications can also be used. First, you try bupropion. If not successful, you can also try varenicline, but it is very expensive. Both of these can be combined with NRT, such as nicotine gums, patches, or lozenges, for better effect and better prognosis. PCP intoxication, like I told you, it's an emergency. So you have to calm the patient, reduce environmental stimulation such as noise, light, and all that. And you can use benzodiazepines. Opiates or opioid dependence. If the person has taken an overdose, then you have to use the specific antidote, which is naloxone. Abstinence therapy, that is reducing the craving, is also possible by using naltrexone, but it carries a poor success rate. Therefore, you can go for ORT, which is opioid replacement therapy. Two drugs under that, methadone, high success rate, but it is addictive. So you can't prescribe. The person has to come to the center to take the medication under supervision. And the other one is buprenorphine, which also has high success rate, and it is less addictive. Therefore, prescribing is possible for buprenorphine. You can also have NA or Narcotics Anonymous. They are all self-help groups, voluntary groups, where people with the same problem get together and discuss how to handle the situation. Alcohol use disorder, withdrawal features. Typically, you have to detoxify them by giving IV fluids because they will be dehydrated. Vitamin deficiencies are seen, therefore you have to replace by giving vitamin B12, folic acid, thiamine especially, and pyridoxine. And of course, for the withdrawal tremors and agitation, you can control by giving benzodiazepines, especially long-acting benzodiazepines such as chlorodiazepine. If the person is also hallucinating and behavioral disorder is also seen, then you might have to use antipsychotics as well. Aversive therapy means you cause a dislike for the use of alcohol by giving anti-abuse drugs such as disulfiram. So what is the dislike? It causes nausea, breathlessness, hypotension. Because it causes hypotension, it can be fatal. It is very sensitive. Therefore, you have to take written consent and educate the patient, saying that this is very sensitive. You should never drink even a minute quantity because it can be fatal. So you are giving something to reduce the drinking behavior. So basically, as far as reinforcement schedules goes, it is an example of positive punishment, right? Anti-craving medications for alcohol, they act by reducing the desire for taking alcohol. Naltrexone, the same one which is used for opioids, can also be used in alcohol. Acamprosate is more commonly used. SSRIs are also anti-craving for alcohol, but you can use them for dual diagnosis such as depression with alcohol use disorder. And of course, baclofen, which is a neurological medicine, can also be used as anti-craving in higher doses. Other types of therapies, behavior therapy is very important. You have to combine that with other therapies. Avoiding cues or triggers for drinking, such as not going in the road which has a bar or a club because you'll be tempted to drink, or not hanging out with friends who are also heavy drinkers and not keeping drinks at home. So any trigger for drink has to be avoided. And of course, there are self-help groups. Alcoholics Anonymous, AA is an example. Okay. Sleep disorder, stages of sleep. That's why it's light here and it gets darker as you go in deeper into sleep. When you are awake and alert, you have beta waves in your brain in the EEG. Awake, relaxed with eyes closed, alpha waves. Stage 1 NREM, theta waves. Stage 2 NREM, very, very specific type of EEG waves called sleep spindles, K complexes. Okay, that is present only in stage 2. Stage 3 and 4 NREM, they are clubbed together because the features are the same, which is delta waves. After stage 1 to 4 NREM, you have REM. There you get desynchronized waves, which have sawtoothed appearance in EEG. And the further difference in NREM, the mind is relaxed. So that's why you have all these waves. But the body is active, okay, is moving about. There is no hypotonia. Whereas in REM, the mind is overactive, brain is overactive. That's why you get sawtoothed appearance. But the body is paralyzed due to hypotonia. Understood? That is the difference. So accordingly, you have all these conditions. Insomnia, general terminology for excessive daytime sleepiness because they are unable to maintain or sustain sleep during the night. So this should happen 3 or more times in a week for 3 or more months. 3 or more episodes of insomnia for 3 or more months. That is insomnia disorder. Hypersomnia, excessive daytime sleepiness, even with sufficient sleep. Again, 3 or more per week for 3 or more months. Sleeping very well, but still feeling sleepy. Obstructive sleep apnea or hypopnea. EDS, that is excessive daytime sleepiness due to hypoxia or throat obstruction. That is what is causing the sleep apnea. You can see thoracic effort in polysomnography. PSG means polysomnography. Thoracic effort is there because they are exerting the effect because of the blockage in the pharynx. Central sleep apnea, the central sleep area in the brain is affected, and that also leads to hypoxia. Therefore, there is no thoracic effort in PSG. That is the differentiating factor. Narcolepsy is a genetic condition where there is excessive daytime sleepiness characterized by sleep attacks, just falling asleep, nodding off, 3 or more episodes per week for more than 3 months. Along with cataplexy, that means sudden entry into hypotonia. Excitement can cause sudden entry into hypotonia and the person just collapses. That is cataplexy. Or reduced hypocrotin or orexin level, where in the CSF. Okay, you can measure the CSF hypocrotin level and that's reduced. Or polysomnography findings, such as sleep onset REM, that's what leads to cataplexy. Or reduced sleep latency. You don't go through stages in REM 1, 2, 3, 4 directly into REM. Therefore, the person collapses. So cataplexy or reduced hypocretin levels or PSG findings of reduced sleep latency. Along with excessive sleep attacks, 3 or more episodes per week for 3 months. That is narcolepsy. Circadian rhythm sleep-wake disorder, sleep disruption from mismatch between internal and environmental demands, such as shift work, jet lag, long distance air travel, seasonal daylight variation, winters it becomes dark very soon. Sleepwalking, rising from bed and walking about while in NREM sleep, because body is active in NREM, sleepwalking can occur. Sleep terror, screaming while in NREM sleep. Therefore, because NREM sleep is more during the first half of sleep, first 1/3 of sleep, you get more sleep terrors. High autonomic nervous system arousal, such as sweating and all that. They cannot recall what happened, what they saw. And next day amnesia also. They can't recall what happened during the night. Nightmares, on the other hand, unpleasant dreams while in REM sleep, because dreams occur mainly in REM. And REM, as I told you, it progresses more and more as the sleep progresses. Therefore, second half of sleep, you get more nightmares. Not much autonomic nervous system arousal. Good content recall. They can recall the content of the dream, bad dream. And next day recall of event is also there. I had such a terrible dream last night, a nightmare. Okay, that's the difference between night terror and nightmare. REM sleep behavior disorder, motor movement during REM due to lack of atonia. There is hypotonia or paralysis during REM that is lost sometimes, and therefore you have motor movements such as gesticulations, even vocalizations can also occur, such as speaking, grunting, and all those things during REM sleep. Restless leg syndrome, volitional. That means under the voluntary control of the patient. Patient is moving the leg. Volitional leg movement in response to tingling feeling. Some uncomfortable tingling sensation is there in the legs. Therefore, the patient moves the legs. While awake, key features, volitional and while awake. Difficulty in falling asleep leads to excessive daytime sleepiness. Whereas periodic limb movements, repetitive muscle contractions, involuntary muscle contractions, patient is not aware during sleep. That is the difference. And because it's NREM, so first 1/3 of sleep during NREM stages, patient is unaware of the movements, they're involuntary. Sleep stage arousals during the sleep lead to excessive daytime sleepiness. And you need the electromyogram because subtle muscle contractions are happening. That can be only caught by doing EMG. EMG, remember, can be part of PSG, polysomnography. Ocular pressure, muscle pressure, blood pressure, all those things are part of polysomnography. Gender dysphoria. Birth gender does not equate to psychological or experienced gender. The person is dissatisfied with their external genitalia. It causes significant distress or impairment, which affects their daily life and relationships and everything. And as a result of that, they feel very distressed. They can cross-dress. Cross-dressing is because they are not satisfied with their the birth gender, okay? Not the paraphilia kind of cross-dressing. Here, the underlying theme is because transsexualism, that is gender dysphoria. They're unhappy with their sex. They want to change it. And these symptoms have to be present for at least 6 months or more. Sexual dysfunctions, there are 4 stages to normal sexual contact: desire, arousal, orgasm, and restitution or refractory period. And accordingly, during each of these stages, you have disorders in both men and women. So in the desire stage, you have male hypoactive sexual desire disorder, where there is reduced libido, and women can also have reduced libido. Arousal stage, men can experience erectile dysfunction. That means penile erection is not enough to achieve penetration. Painful erection is also possible. In women, female sexual interest or arousal disorder, that means they do not um, get aroused during the sexual act, or genitopelvic pain or penetration disorder. They experience pain during sexual contact. Orgasm, men can experience premature ejaculation, very common. That means not having sustained erection to consummate the sexual act. And delayed ejaculation, which is very, very rare in men. Premature ejaculation is much more common. Women, female orgasmic disorder, also known as anorgasmia, that means they're unable to achieve climax orgasm. Okay, so let's look at each of these stages. Desire stage, you have drives, motivations, and urges to have a sexual act. In men, males, hypoactive sexual desire, no fantasies or desires, which is very rare in men. Therefore, you have to rule out depression, low testosterone levels, stress, marital problems, all those things. In women, it is reduced libido. It is more common among women than in men. Arousal stage, there is sexual arousal and physiological response. Autonomic nervous system is active, especially the sympathetic system. In men, erectile dysfunction or disorder, inability to attain or maintain erection until completion of the sexual act. You have to rule out secondary conditions such as alcohol, smoking, or other drugs, diabetes and treatment for diabetes, and marital conflict. In women, female sexual interest and arousal disorder, inability to achieve or maintain lubrication during the sexual act, by which I mean the vaginal lubrication. 1 in 3 women experience this. You have to rule out intake of medications such as antihistamines and anticholinergics, which can dry out the secretions. Pain may occur during the arousal stage, so it is a subjective sense of pain during the sexual act that can lead to painful erection in men. And in women, a particular condition called genitopelvic pain or penetration disorder, difficulties in vaginal penetration or vulvovaginal or pelvic pain. So it could be vaginal pain or pelvic, outside the vagina, pain during intercourse or penetration attempts. And in the last stage, orgasmic phase, contractions of organs is seen in both the sexes. Sexual tension is released. Parasympathetic system is more active. That's why the contractions are achieved. In men, there is premature ejaculation before the man wishes, before penetration, or just after penetration, there can be ejaculation. So this could occur due to having a public intercourse, such as with prostitutes or commercial sex workers in the backseat of a car where the person has to hurry up. But you have to rule out secondary medical conditions such as prostatitis. Prostatitis means inflammation of the prostate, or thyroid disease. There can also be delayed ejaculation, delay or absence of ejaculation, but that's very rare in men. In women, female orgasmic disorder, also called anorgasmia, there is inability to achieve an orgasm by masturbation or intercourse. 1 in 3 women experience this, but the likelihood of orgasm, they say, increases with the age as the woman becomes more comfortable with her, the physical aspects of her anatomy. Okay. Then you have the paraphilias, deviation from usual sexual behavior manifested by fantasies, urges, or behaviors. They are intense and persistent for at least 6 months. Please remember that paraphilias could be indulged in normally also. So when do they become disorders? So paraphilic disorders are characterized by when they involve non-consenting person or acts on the urge with a consenting person or thing, and the action causes significant distress or functional impairment. Or on the other hand, the person does not act on the urge, but the urge itself is causing significant distress or functional impairment. Any one of these 3 situations, non-consenting person, act causing distress, or the urge causing distress. If it is occurring, then that is paraphilic disorder. Subtypes of paraphilic disorders: voyeurism, achieving arousal or climaxing by observing others. And the person who is doing voyeurism is more than 18 years of age. Exhibitionism, opposite, that is arousal by exposing genitalia to unsuspecting people. Frotteurism, arousal by touching or rubbing genitalia against somebody else. Fetishism, arousal by non-genital body parts such as hands and legs, for example, or non-living objects such as underwear, some other clothing or whatever. Transvestic disorder, as the name indicates, trans means other and vest means dress. So arousal by cross-dressing. They definitely get aroused by cross-dressing. It's like an urge to cross-dress. Sadism, arousal by causing suffering, and the suffering can be both physical as well as psychological. They give suffering to others and they get aroused. Masochism is opposite of sadism, arousal by receiving suffering, and again the suffering can be both physical or psychological. And because there is a giver and a receiver in these conditions, they are considered together sadomasochism. Okay. Pedophilia is both a disorder as well as a crime, please remember. It is child sexual abuse by a person who is more than 16 years of age. That means the perpetrator is more than 16 years of age, who is at least 5 years older than the victim. And the victim should be less than 13 years of age, or more importantly, of the pre-pubertal age group. Moving on to neurodevelopmental disorders, intellectual disability is defined as IQ less than 70 or equal to 70, plus deficits in adaptive functioning, that is, activities in daily living are affected. Both have to be present. And IQ, as you know, it has to be measured using standardized tests of IQ, such as WAIS. Specific learning disorder, difficulty learning and using academic skills. Okay, so specific problems with reading, which is called dyslexia, or writing, dysgraphia, and or maths may be present, in which case it is called dyscalculia. They interfere with the functioning, that means academic functioning is also affected. Skills that the child has is less than what is expected for the child's age, and manifest when academic demands exceed the capabilities. So as the child progresses in the school to higher and higher standards or classes, the defect becomes more and more apparent. Okay, they are unable to cope. So that's what happens. So in all these things, it is supportive therapy. There is no specific therapy as such. Communication disorders where language is affected. Under this, you have 4 types. Language disorder, where language acquisition and use of language itself is affected. That means the vocabulary itself is very poor. Okay. Speech sound disorder, problems with pronunciation. Childhood onset fluency disorder, as the name indicates, there is problem with fluency or timing of the speech. Typically manifests as stuttering or stammering. Social or pragmatic communication disorder, problems with social use of language, such as verbal and non-verbal communication. That is the emotional aspect of language, body language, facial expressions. All those things are difficult for people with social pragmatic communication disorder to handle. Okay. Tourette's disorder, wherein you have multiple motor tics. That is very important. First thing that is required is multiple motor tics plus one or more vocal tic. So it may be just one vocal tic, but multiple motor tics have to be present sometime during the illness. And the symptoms should last more than a year. Onset is in the developmental period, that is before 18 years of age. The treatment for this, psychotherapy such as stress reduction, because stress brings on the tics, and teach them coping strategies, such as if it is swearing due to vocal tic, they might have to move out of the room or suppress the swearing somehow. So teach them all those kind of coping strategies. Pharmacologically, you can use antipsychotics to control the tics. And one specific drug that can be used in Tourette's disorder or tic disorder is tetrabenazine. Persistent or motor or vocal tic disorder. So here you have motor or vocal tics, and it has to last more than 1 year, just as in Tourette's disorder. But in Tourette's, you need both motor and vocal. Okay. Provisional tic disorder, motor with or without vocal tics, but lasts for less than 1 year. Continuing with the neurodevelopmental disorders, you have autism spectrum disorder or ASD. You need both, that is, deficits in social communication and interaction, along with restricted repetitive behaviors or interests. That means social communication is affected. They can't make good relationships. They don't play with other children. Restricted repetitive interests or behavior, they stick to only one kind of activity. They have repetitive body rocking movements. They have odd interests and they stick to that. Any change and they get very upset. Management applied behavior analysis, which is basically behavioral therapy that we discussed. All those things have to be put into action, such as token economy and reinforcement schedules, all those things. Social skills and communication training, if possible. If it is a milder form of autism, then you can consider those. Then you have attention deficit hyperactivity disorder, or ADHD. You have three types under this. One is inattentive type, wherein you have 6 or more symptoms of inattention, but less than 6 of hyperactivity or impulsive subtype. On the other hand, hyperactivity impulsive subtype has 6 or more symptoms of hyperactivity or impulsivity and less than 6 of inattention. Combined type, it has more than 6 of both inattentive symptoms and more than 6 of hyperactive and impulsive symptoms. So you will have to look at the list of symptoms under inattentive type, like forgetfulness and all those things. Hyperactive, not sitting in one place, impulsive, blurting out answers, not waiting for a turn, those sort of things. So we'll have to look at all those symptoms and try and remember them. What can you do with in ADHD? First of all, psychosocial interventions, individual therapy. You have to train the child to stop, think, and act. Okay, family support, make them understand the condition, and get them to use token economy, such as star charts. If you behave well, you'll get a star that can be exchanged for gifts or treats. Medications do have a big role in ADHD, and they are all amphetamine derivatives, dexamphetamine, methylphenidate, and all those things. Basically, they act by increasing the dopamine and norepinephrine level at the prefrontal cortex region. Side effects would include appetite loss, insomnia, headedness, GI upset, cardiac events, growth retardation, and potential for abuse. So that's why they are controlled prescriptions, because amphetamines are street drugs, so they can be abused. Monitor everything, that is pulse, BP, height, and weight have to be monitored before and during therapy with stimulant medications. Non-stimulant medications, atomoxetine, tricyclic antidepressants, and clonidine. Okay. Atomoxetine acts by increasing norepinephrine level at prefrontal cortex, but side effect of atomoxetine can increase suicidal ideas. These non-stimulant medications are used if there are stimulant failures. That means you are given stimulant medications and there is no response, or if there are any contraindications to using stimulants, such as abuse, growth retardation, or tics, epilepsy. All those things could be contraindications to stimulants, in which case you go for non-stimulants. And TCAs and clonidine, they may be combined with stimulants or non-stimulants as well, but that will be polypharmacy, so we'll have to watch out for the increased risk of side effects. Disruptive impulse control and conduct disorders, oppositional defiant disorder, or ODD, defiant behavior. That means if you tell them something, they'll do the opposite. Okay, but no serious violation of rights or norms. Don't go around vindictively attacking people. And other thing about ODD, it can be diagnosed in both children and adults. Okay, conduct disorder, CD, serious violation of rights or norms. That means they vindictively do attack other people. Instrumental violence, that means there is a purpose to the violence, such as going and attacking somebody and robbing them. Okay, plus similar features to antisocial personality disorder in younger age and diagnosed in children and adults. Okay, subtypes of CD, childhood onset before 10 years of age, adolescent onset after 10 years of age. Antisocial personality disorder, ASPD, again serious violation of rights and norms, instrumental violence, violence for getting something, no insight. That means they don't understand the wrongness of their actions. No remorse, that means they do not regret what they have done, they don't feel sorry for their victims. And no empathy, that means they do not understand others' feelings. In other words, they treat people as inanimate objects that they can inflict violence on. Okay, this is definitely an adult condition, so it has to be diagnosed after 18 years of age, and conduct disorder symptoms should have begun before 15 years of age. So that is an additional requirement in ASPD. Moving on to IED, that is intermittent explosive disorder, severe temper outbursts, usually due to frustration, but along with normal baseline mood. So it is episodic, that's why it's called intermittent. Okay, and it has to be diagnosed in children more than 6 years as well as adults. Kleptomania, there is irresistible stealing with pleasure or gratification. Typically, the tension keeps building, and to relieve the tension, they will have to steal objects, often which are of no value to them, okay, and they may even return the object. And this is different from shoplifting, where it is instrumental shoplifting. That means they want the item. That's why they are lifting. So that is a crime. Whereas kleptomania is a disorder. Okay. Pyromania, this is also a disorder where again there is tension and they relieve the tension by deliberate fire setting, and that leads to pleasure or gratification. Again, this is not arson, which is a crime where there is instrumental fire setting, such as to take revenge on somebody, you destroy their property by setting fire to it or something like that. So it is not arson crime. It is a pyromania is a mental disorder. We have included adjustment disorder or disturbance of conduct because there are similarities. Serious violation of rights and norms are still seen here, along with disturbance of conduct, but there is usually causal stressor, and usually it is a psychosocial stressor, such as moving to different city, getting divorced or something like that. And it's a diagnosis of exclusion. So you have to rule out all these things: conduct disorder, depression, anxiety, rule out all of them before you make a diagnosis of adjustment disorder. DMDD or disruptive mood dysregulation disorder, childhood condition characterized by severe temper outbursts and irritable or angry baseline mood. So that is the difference between IED and DMDD. In IED, there is normal baseline mood. Mood does become euthymic after the episodic temper outburst. Whereas in DMDD, they are always irritable, plus have temper outbursts. Conceptualize DMDD as severe oppositional defiant disorder, and it is diagnosed only in children of 6 to 18 years of age, not in adults. And the onset has to be before 10 years of age. Eating disorders, anorexia nervosa, BMI definitely has to be less than 18.5 kg per meter square. Weight in kg divided by height in meter squared, that is BMI, it has to be less than 18.5. Fear of gaining weight should be present. Distorted judgment of body image. They don't like what they see in the mirror, basically. Okay, they feel they are too fat. Subtypes: binge eating or purging subtype. Here you have to remember it's underlined overeating because overeating takes precedence. That means binge eating takes precedence. If there is only binge eating, even without vomiting, it is still called binge eating purging subtype. Okay. Other subtype is restricting subtype. That means fasting, not eating at all, with or without over exercising. Again, fasting is underlined because fasting takes precedence. So it could be just be fasting and starving without exercising. It is still restricting subtype. Binging supersedes purging and restricting. So in order of hierarchy, binging comes first. So basically you have to rule out binging if you want to consider restricting subtype. Physical complications, amenorrhea could be one of the features of anorexia, loss of menstruation, loss of sex drive, constipation, hypotonia, low blood pressure, and bradycardia, low heart rate, hypothermia, low temperature, hair loss, lanigo hairs like childlike, infant-like hairs, dry skin, brittle nails, hormone deficiency, organ failure, brain changes, and death. That's why the mortality rate is very high in anorexia. Features of excessive vomiting with binge eating or purging subtype could be tooth decay, swollen salivary glands, Russell sign, which is lesions on the knuckles because of inserting the hand to vomit, and GI tissue tears because vomiting can be very severe and cause gastrointestinal tears. Focus should be on weight gain in management, cognitive behavior therapy. Psychotherapy comes first. Only after that, consider antidepressants such as SSRIs, but they are off-label, okay? Not really used routinely. Then you have bulimia nervosa, which is binge eating has to be present along with inappropriate compensation. So both binge eating and vomiting or purging. BMI could be normal, that is 18 to 25, or high, more than 25. No subtypes in bulimia. Because of vomiting, there can be electrolyte imbalance, irregular heartbeat. Again, features of excessive vomiting such as Russell sign, tooth decay, GI tears, and all those things could be present. CBT, first choice. Consider antidepressants such as SSRIs as adjunct to CBT. Binge eating disorder, binge eating without inappropriate compensation, just binge eating spells or episodes. Okay. So therefore, because there is no compensatory behavior, BMI is high, and they can go into obese range also, which is more than 30. Okay. Again, no subtypes. Obesity is a consequence of binge eating disorder, and therefore they can have further complications such as metabolic syndrome, high mid-arm circumference, high cholesterol level, diabetic, all those things, which increases the cardiovascular risk factors, stroke, heart attacks, and all those things. CBT and other antidepressants as adjuncts. If it is not fitting into any of these, unspecified eating disorder, other body image or eating disturbances not meeting the criteria for above disorders. No subtypes, of course. We have a flow chart which is here. Ask yourself these questions. If you are faced with a eating disorder question, first of all, what is the BMI? That's the first question you need to ask. If it is low BMI, could it be anorexia nervosa? Then consider the criteria for anorexia nervosa. Low BMI, less than 18.5, intense fear of weight gain, body image disturbance. All are present, then it is anorexia. Then you have to ask yourself, what subtype of anorexia could it be? Is it binging with or without purging? If that is present, then it is binge eating or purging subtype. If there is not there, then it is restricting subtype. That is avoiding food. Yeah. So going back to BMI, if the BMI is normal or high, then you have to consider, could it be bulimia nervosa or binge eating disorder, right? Then you ask yourself, is it binge eating associated with inappropriate compensatory behavior? If both are present, then it is bulimia nervosa. If it is only binge eating episodes, it is binge eating disorder. If it is not fitting into any of these questions, you cannot answer convincingly, then you go for unspecified eating disorders. Memory and the amnesia related disorders. Very briefly, memory, sensory memory is just a fraction of a second that takes in the information, passes it on to working memory or short-term memory, which is less than 1 minute. Capacity is 7 plus or minus 2 units. And if you can do encoding, that can be shifted to long-term memory, which is for lifetime. Okay, and its capacity is endless. Long-term memory can be divided into explicit memory and implicit memory. Explicit memory means it's conscious, you are aware of it. Under this, you have declarative memory for facts and events. So if it is some experiences or events in some person's life, then that is known as episodic memory. If it is facts and concepts, such as what you are learning now, that is part of semantic memory. So the episodic life events and all those things, it's also known as autobiographical memory. Then unconscious memory is implicit memory. That means it is already there, it's always there. It is there in the mind. The person does not have to recall with any effort. It will come automatically. And typical examples are procedural memory, such as skills and tasks. Best example is learning to ride a bike. First time it is a bit of a struggle, but when you learn, it's for life. It's part of implicit memory. It is always there. You don't have to relearn how to ride a bike each time you get onto a bike. Understood? So that is implicit memory or procedural memory. Amnestic profile, how does a person with amnesia look? Remember, amnesia is not dissociative amnesia. This is organic amnesia. Okay, and there is an underlying cause for this kind of amnesia. It's of two types, retrograde amnesia and anterograde amnesia. So before the injury, if there is memory loss, that is retrograde amnesia, characterized by problems retrieving long-term memory. Recall is affected. Whereas anterograde amnesia occurs after injury, okay? Here there is problem encoding and consolidating the memory. That is basically turning STM, short-term memory, into long-term memory is problematic. In retrograde amnesia, there is a special feature known as temporal gradient. That means time-related gradient, which means basically if there is a memory that is closer to the injury, it has poorer recall. So recent long-term memory is lost. Whereas remote long-term memory or events that have happened several years before the injury, there is better recall. So that is known as a temporal gradient. Poorer recall closer to the injury, better recall for more remote long-term memory. And in anterograde amnesia, declarative or episodic memory, autobiographical, turning that into long-term memory is affected. That's what we mean. Differences in terms of language for the hemispheres. Please remember, left hemisphere is dominant in 96% of cases. It's opposites, right? So even if a person is left-handed, even there, the dominant hemisphere is the left hemisphere. Okay. So the left hemisphere, briefly, it is concerned with language, understanding, as well as expressing. So that's why both the Broca's and Wernicke's areas are on the left hemisphere, okay, which is the dominant hemisphere. So lexicon, which has two meanings, dictionary and vocabulary, and the phonetic sound-related assembly and procession, they are all a feature of left hemisphere. Right hemisphere, communication and emotional prosody, that is stress, timing, intonation, interpretation of language, pragmatics of language, making up a story, understanding jokes, sarcasm, reading between the lines, emotional aspects of language, all those are a part of right hemisphere. Please remember, Wernicke's, Broca's areas, they are on the left dominant side. So accordingly, you can have Broca's aphasia, which occurs due to left interior frontal cortex damage. Basically, frontal lobe is affected. This is the area where Broca's area is present, and therefore, if that is affected, you have Broca's aphasia. On the other hand, Wernicke's aphasia damage due to posterior sector of left auditory association cortex. Temporal lobe is affected, which is here. That is where the Wernicke's area is present. And if that is affected, you have Wernicke's aphasia. And please remember, look at both the sides, left frontal, left auditory. So that means what? Left side, the dominant side is affected in both. Only Broca's is in frontal area and Wernicke's is in temporal area. So what is the difference in the two types of aphasias? Broca's aphasia is motor aphasia. So you have stuttering and effortful speech. Pronunciation is affected. Whereas in Wernicke's, normal pronunciation, fluent, loquacious, lot of language, fluent, but it doesn't make sense. Speech content, there could be missed syllables, agrammatical and telegraphic speech. Association words are missing. That's what we mean. That's what we mean by telegraphic speech. That is seen in frontal aphasia or Broca's aphasia. Wernicke's, use of wrong or non-existent words. Comprehension of spoken language, normal. Understanding is not affected in Broca's aphasia, whereas understanding is definitely very, very abnormal in Wernicke's aphasia, which is receptive aphasia or temporal aphasia. Now, comprehension of written language, not as good as spoken language. For Broca's aphasia, Wernicke's abnormal, but better than spoken. Writing, because it's a motor activity, remember. So Broca's is motor, right? So clumsy, agrammatical, and misspellings are seen in Broca's aphasia. Whereas Wernicke's penmanship is okay, writing is okay, but misspelling and inaccuracies are seen. Naming objects, it is better than spontaneous speech in Broca's aphasia. Definitely very abnormal in Wernicke's aphasia, characterized by wrong names, paraphasias, and neologisms, coining new words which do not exist in the lexicon or dictionary. That is a feature of Wernicke's aphasia. One more difference you can add, lack of insight in Wernicke's aphasia. Okay, so let's look at the summary. Amnesia, acquired memory loss, very important, not dissociative memory loss, where new learning is not affected and some psychological trauma is there. Here there is organic problem, medical problem is there. As a result of that, there is acquired memory loss. No other cognitive domain is affected. Okay, that means like in dementia, you don't have what? Disorientation, language difficulties, apraxia, and all those things. An underlying cause is present in amnesia. Okay, retrograde amnesia, long-term memory loss before the injury, declarative or autobiographical memory loss is seen, temporal gradient is seen. Memory close to injury is lost, poorer recall. Anterograde amnesia, memory encoding and consolidation loss after injury. Therefore, learning new information is affected. Converting STM into LTM is affected. Implicit and procedural memory is usually intact. That means, learning the bike, if you have already learned the bike, that is not affected. Okay, that is always present. Wernicke's encephalopathy, remember it's considered together as a syndrome, Wernicke-Korsakoff syndrome. First, the person can have Wernicke's encephalopathy, which is a triad characterized by confusion, ataxia, that is abnormal gait, and eye signs such as drooping of eyeballs due to paralysis of external ocular muscles and all that. It happens due to thiamine deficiency, long-term chronic thiamine deficiency. Several causes for thiamine deficiency: alcohol dependence, starvation, and chemotherapy. Commonest is alcohol dependence. Good news is Wernicke's encephalopathy is reversible if thiamine can be supplemented and the person, stops starving, taking alcohol, stops the chemotherapy or whatever. If not, the condition progresses to Korsakoff's psychosis, which is like a severe dementia characterized by global amnesia, memory loss throughout, and confabulation, which is falsification of long-term memory gaps, filling the gaps in long-term memory with false information which never occurred. Okay, this is also due to thiamine deficiency, alcohol, starvation, or chemotherapy, and prognosis is very poor because it is irreversible, leading to death. Brokaw's or expressive aphasia, motor aphasia. Okay, stuttering speech, missed syllables and/or words, understanding other speech is not affected, it's normal. Writing difficulties are seen because motor activity is involved there, and naming objects is usually preserved. Wernicke's or receptive aphasia, understanding is affected, but motor production is not affected. That's why the speech is fluent but senseless. They cannot understand other speech and instructions. Reading difficulties are there because that involves looking and understanding. And naming objects is affected. Coining new words may be seen, and no insight, very important. Okay. Dysarthria, slurred speech due to articulation defect. Pharynx, tongue, palate, lips, or facial muscles are affected due to some cranial nerve palsy, for example. Dysphonia, hoarse voice due to phonation defect. Air entry through the larynx or vocal cords is affected. So recurrent laryngeal nerve palsy can cause that. Apraxia, inability to do skilled activities, previously learned activities are affected. Parietal lobe is primarily affected here. So examples would include things like not being able to dress up, make a cup of tea, or construct a star shape using matchsticks. These are the examples for apraxia. Agnosia, inability to recognize objects, faces, or body parts. Familiar stimuli, the person cannot recognize. So because there is seeing also involved, the occipital lobes are also involved because the optic tract ends in the occipital lobes. Primarily, it is a disorder of parietal lobe. Okay. Examples: not being able to recognize fingers, faces, and all those things. So apraxia, agnosia, primarily parietal lobes are affected. And the A's, amnesia, aphasia, apraxia, and agnosia are features of dementia, which we are going to look at now. So continuing with neurocognitive disorders, delirium, reduced awareness and attention. Okay, that is very important. Primary criteria for delirium: reduced awareness and attention. Multiple cognitive deficits are seen, such as language, disorientation, and all those things. It is sudden onset. Fluctuating consciousness or cognitive abilities are seen, and it is due to an underlying cause. Sudden onset due to underlying cause, reduced awareness and attention, very important. So the underlying cause could be medical illnesses or substance intoxication or withdrawal, both can cause. NCD or neurocognitive disorders, this is the DSM-5 accepted terminology. Major NCD, there is significant decline in one or more cognitive domain. It interferes with activities of daily living. Minor NCD, modest decline in one or more cognitive domain, does not interfere with activities of daily living. A related terminology, mild cognitive impairment or MCI, it is mild decline as the name indicates, and of course it does not interfere with ADLs. Dementias are multiple cognitive deficits without clouding of consciousness. That is the difference between delirium and dementia. In delirium, you have fluctuating consciousness and cognitive abilities and reduced awareness and attention. Whereas in dementia, clear consciousness. Subtypes of dementia, commonest subtype is Alzheimer's, where there is gradual onset and progression. Parietal and temporal lobe abnormalities are significant, and memory encoding deficits are seen, so learning new information is affected. Recent long-term memory loss is seen because long-term can be divided into recent and remote long-term memory. Recent means what happened this morning, what breakfast did you have, who were you with last night, those kind of information is lost. Aphasia, apraxia, agnosia are seen as we discussed. Delusions may be present, especially paranoid persecutory type of delusions, and loss of insight, very important. Loss of insight is not seen in the next commonest type of dementia, which is vascular dementia, which occurs due to cardiocerebrovascular diseases such as acute myocardial infarction, stroke, hypertension, diabetes, or their treatment may also be present in the history. Stepwise progression, cognitive decline due to vascular insufficiency, and then there will be a plateau during which the cognitive function is okay. And then again, there is some vascular insult to the brain, and again, there is deterioration in the cognitive function. That's what we mean by stepwise progression. Focal neurological signs may be seen because some part of the brain may be affected. The function of that particular part is affected, such as paralysis of one limb, for example, could be seen. Concerns about memory loss, that's what I mean by insight is present in vascular. They actually present to you saying, after having the stroke, my memory is not the same, so please do something. Whereas in Alzheimer's, they will not present because they don't think they are ill. So if you ask questions to test their cognitive ability, they may get irritable in Alzheimer's. Frontotemporal dementia, as the name indicates, there is a dementia with prominent frontal and temporal lobe features. Frontal lobe symptoms such as disinhibition and personality change, sexual disinhibition, swearing, and all those things could be seen. Earlier age of onset, 40s and 50s, fourth and fifth decade. Okay. Example of frontotemporal dementia is Pick's disease. Then you have Parkinson's dementia, wherein basically cognitive deficit happens in the background of motor symptoms such as tremors, rigidity, and shuffling gait. Then you have cognitive decline, and the dementia therefore occurs after 1 year, more than 12 months of motor symptoms. Lewy body dementia, characterized by fluctuating cognition, visual hallucinations, mild motor symptoms, dementia of less than 12 months of motor symptoms, and neuroleptic hypersensitivity. That means increased chance of having extrapyramidal side effects with antipsychotic treatment, even if you're giving a low dose of antipsychotic medication. So the key feature to differentiate from Parkinson's, in Lewy body, the condition is sort of coexisting, occurring almost together with motor symptoms. Okay. Tremors are not usually seen, muscular rigidity may be seen, and abnormal gait might be seen. So less than 12 months of motor symptoms. Visual hallucinations, very prominent, and neuroleptic or antipsychotic hypersensitivity. Don't forget, it's called Lewy body dementia because you have Lewy bodies in the brain of these people. Just like in Alzheimer's, you have amyloid plaques and neurofibrillary tangles. Okay. Then Huntington's disease, it is a genetic condition, autosomal dominant condition, characterized by coriform or orthotoid movements, dance-like writhing movements. Behavioral disorder is seen. Dementia after motor or psychiatric symptoms. So here also the cognitive deficits occur after behavioral disturbance or these dance-like movements. Then you have Creutzfeldt-Jakob disease, dementia with rapid progression, characterized by jerky movements, not dance-like movements, don't get confused. Writhing or dance-like movements is part of Huntington's disease. Jerky movements is part of CJD, okay? And rapid progression, prognosis is very poor, death occurs within 1 year. And usually there is a history of exposure to prion, which is a non-living proteinaceous substance, which can be transmitted from person to person, infected meat. And once it enters, it behaves like a living organism, like a virus, and causes CJD. CJD is an example of a prion disease.